with the composite restoration chips off. That is because this composite restoration is not able to deflect the forces. So an ideal restorative material should be able to deflect the forces which is transmitted onto the tooth structure. So what are the challenges of the traditional restorative materials? It is a wear, the marginal leakage, and the secondary caries. So a bioactive material enhances the mechanical characteristics and a bond strength at the tooth material interface. So the major problem with the secondary caries, it happens at the tooth material interface. So a bioactive material increases the bond strength at the tooth material interface. And bioactive materials have evolved in their composition and has been used in the various fields of medicine and dentistry. So how this biomaterial are classified? The biomaterials used for tissue regeneration and restorative biomaterials. The biomaterials used for tissue regeneration can be divided as the materials for scaffold, the cells, and the regeneration of a periodontal ligament, dentine and enamel, dental pulp, and alveolar bone. Whereas the restorative biomaterials are mainly the materials used for implant processes, materials used for endodontics, mainly MTA and biodentine, and materials for bone reconstruction. So these materials are used in bone regeneration, coating of implants as a cavity basis to reduce the dentinal sensitivity, to remineralize enamel and dentine, as an endodontic perforation repair material. Again, the materials of choice is MTA and biodentine, pulp capping and root canal disinfection, and as endodontic sealers. So what is the goal of this biomaterial? To restore the lost or injured tissue and to encourage the tissue regeneration. So American National Institute of Health defines biomaterial as any material or mixture of materials other than pharmaceuticals that can be used for any length of time and that augments or replaces any tissue, organ, or function of the body entirely or partially to preserve or enhance the quality of the life of the individual. The biomaterials can be classified as bio-inert material, bioactive material, and a bioresorbable material. The term bio-inert refers to any material that once placed in the human body has minimal interaction with the surrounding tissues. The bio-inert materials normally we use are the metals, the titanium, the ceramics, zirconia, and the polymers. Whereas the bioactive materials are materials that elicit a specific biological response at the interface of the material, which results in the formation of a bond between the tissue and that of the material. Examples are bioactive glass, hydroxyapatite, and ceramics. And bioresorbable material, the material that upon placement within the human body starts to dissolve and slowly replaced by the advancing tissue such as bone. Examples are tricalcium phosphate, polylactic and polyglycolic acid, copolymers, calcium oxide, calcium carbonate, and gypsum. In this, when we talk about the dental decay or something about the enamel and dentine, we should not mix matrix metalloproteinases or MMPs. These MMPs are inactive enzymes that are activated by acid and degrade the collagen over a period of time. The most MMPs we should think or worry about is the MMPs 1, 8, 13, and 20, which are important for dentistry. And cathepsin K or CAD-K, which is important in wound healing, tissue repair, and remodeling in response to the injury. So what happens in a tooth development? Formation of the mineralization, the collagen matrix, and during this mineralization time, these MMPs get fossilized inside the dentine or enamel, and upon exposure to the acidic environment, either by the decay, dental caries, by Streptococcus mutans, or by the frequent use of acid etchant, it reactivates the dormant MMPs by a process of cysteine switch mechanism, and MMPs get activated. When MMPs get activated, again, there will be a demineralization both in the enamel and there is a collagen breakdown in dentine. So brief introduction about the evolution of dental restorative materials. So starting from 1920, the calcium amalgam controversy started. Calcium hydroxide And 1930s, acrylic resin and Vitalium screw implant. 1940s, acrylic resin, silicate cement, and silicophosphate cements. And 1950s, the Brennan-Mark osseointegration, electrical tritugators, and polysulfide impression. 1960s, aluminous core, bis GMA monomer for composites, condensation silicon for impressions, copper amalgam. 1980s, the high copper amalgam, polycarboxylate cement, introduction of glass ionomer by Wilson and Kent, and 1970s, addition silicon impressions, automated vacuum firing, effectiveness and Pitt and Fisher sealants, effectiveness is understood, and 1970s, low-cost gold alloys, and 1980s, they started introducing amalgam bonding, CAD-CAM, introduction of the CAD-CAM, advancements in the dentine bonding agents. 1980s is a laminate vernice, started using the laminate vernice, Maryland bridges, 3-step etching procedure and bonding procedure, zinc oxide and EBS cements. And 1990s is a automatic restorative materials, milling techniques, and they started using MTA as a repair material. 2000s, the new introduction of copomers, geomers, layered color printing of maxillofacial processes, lithium disilicate ceramic, selective laser melting, zirconia implants, and 2010 bulk fill composite, CAD-CAM milling composites for crowns, polywave light cure units, and 2020 selective laser sintering, additive layered metal processing, 3D printing, reconstruction, and we are in the process of universal addition. So where are all these materials derived from? The 60% of the dental materials, what we are using today, are borrowed from an industry outside dentistry. The remaining 20% are derived from scientific literature outside dentistry. Examples are ceramics, the chemistry of the various materials, and the material science. And only 20% are developed by the dentist or a non-dentist for dental use. So Hench classifies bioactive materials into two groups, one in which bioactivity leads to induction and production. Induction induces an intracellular and extracellular response, whereas production generates the binding of the material to the hard and soft tissue. And second one is the bioactivity, which leads to the conduction, which lowers the surface reaction and only induces extracellular response. And how will you classify these materials? These materials can be classified as restorative, materials that can remineralize, materials that can desensitize, and materials which has got the property of antibacterial action. So restorative biomaterials induces mineralization of the collagen mesh. And again, I told you, it fossilizes MMPs. So when you see a bonding agent or a composite, it has got two parts, hydrophilic and hydrophobic. The hydrophilic bonds to the dentine and hydrophobic bonds to the composite. And the hydrolysis of this adhesive interface between the dental tissue and the bonding agent of the restorative material determines the longevity of the restorative material. So this restorative interface forms an interfacial layer of apatite crystals of 270 micrometer, and it generates bond by interdigitation. That is, it penetrates deep into the dentinal tubules and increases the adhesive strength. It releases phosphate, calcium, fluoride, and silica ions from saliva, and it generates a structural change by having a chelation reaction with calcium and zinc. Inhibits the action of MMPs and CAD-K, and it preserves the integrity of the mesh collagen within the hybrid layer. The second one is remineralizing biomaterials. especially glass ionomer. So what happens when you do a glass ionomer filling? There is an ion exchange. There is a high concentration of calcium ions close to the interface of the materials. And it favors the precipitation and nucleation of calcium phosphate. That is, that area becomes supersaturated. That is the area the fluid becomes supersaturated. This improves the remineralizing capacity of the ionomers and formation of amorphous calcium phosphate with the growth of hydroxyapatite crystals. The third one is a desensitizing biomaterials. So when you combine bioactive glass with artificial saliva, it forms apatite hydroxycarbonate crystals within the collagen fibers. And these deposits outside the dentinal tubules. And there is a process of remineralization, which causes increase in calcium and phosphate on the surface of the enamel. And there is a polycondensation reaction. Then antibacterial biomaterials, they generate an alkaline medium, the pH between 8 to 9, and it favors bacterial inhibition. Zinc ions bind to proteins of the microorganism, generating structural changes of the membrane, inducing cell lysis. So incorporation of the MDPB monomers creates a long-lasting antimicrobial effect, and it does not compromise the mechanical property of the material. So the bactericidal effect produced by the breakdown of the bilipid layer and subsequent death of the microorganism reduces the formation of the secondary dentine. So MDPP monomer, it can be copolymerized and covalently bound in the resin matrix, and it can become long-lasting immobilized agent and in contact against oral bacteria. It has got antibacterial activity against M. streptococci, lactobacillus, and actinomyces, and it is also capable of eradicating the bacteria from the interior of the dentinal tubules. So what are the bioactive materials in restorative dentistry? First is the composite resin. The composite resin, as I told you, there are 30 to 40% of the literature says in a class 2 composite restoration, the failure rate is around 20 to 30%. Now, what is a composite resin? It contains a bis-GMA, triethylene glycerol methacrylate, tegma, as a organic matrix, and as a fillers, it contains silica, and other different types of fillers are coated with a coupling agent. Okay, so there are 3 areas, that is organic matrix, filler, and a coupling agent. Plus, when you do a composite restoration, there is an interface between the composite restoration and the with protease inhibitory and antibacterial activities have been integrated to prevent adhesive interface degradation thereby reducing the secondary caries. The other bioactive material is the glass ionomer. Again, the glass ionomer, one of the advantages of glass ionomer is a fluoride release. So it increases the acid, carrying out a buffering effect. So bioactive glasses together with the ionomers favor the formation of the hydroxyapatite in the collagen mesh exposed in an acidic environment, improving the mechanical properties of the dendine in its remineralization process. This ionic precipitation occludes the dendrital tubules, thereby reduce the movement of the dendrital fluids. So this is an important desensitizer. So the other bioactive material is the ACP CCP, that is amorphous calcium phosphate, which is stable calcium and fluoride ion precipitator and promotes the formation of hydroxyapatite. But the problem with ACP is it is highly soluble in the aqueous media and it rapidly converts into the hydroxyapatite. To stabilize ACP, casein phosphopeptide or CPP is added and it forms a complex of CPP, ACP, favoring the saturation of the fluoride and the phosphate ion in saliva and the bacterial plaque, generating its anti-karyogenic and remineralizing benefits. So what is the advantage of this paste? It considerably reduces the roughness of the enamel, because the roughness of the enamel is necessary for the addition of the biofilm. It lowers the surface energy and it hinders the adherence of the biofilm in the early stages of caries development. By raising the surface hardness values in tissues demineralized by the acidic environment created by the bacterial attack. The other one is a bioceramic material. It consists of silicates, aluminates, and hydroxyapatite. It is synthesized by different methods, by the fusion, vapor deposition, and gas synthesis. And adhesive property, and it has got an adhesive property to the tissue and ionic precipitation. Bioactive glass, it facilitates the degradation of proteases, favoring the bond strength. It decreases the hydrolytic degradation of the adhesive interface, and it generates antibacterial environments, and it decreases microfiltration, and it decreases the recurrent caries. Then the important one is the silicate-based restorative materials. The important one is the MTA. It has got an antibacterial property and an alkaline pH, favors the formation of the dendine bridge in pulpal repair. And MTA promotes osteoblastic development, and MTA has got a good sealing ability and it favors biocompatibility. It can be used in direct or indirect pulp capping, and it has got a capacity to cure up to the depth of 1 to 7 millimeter and may reduce the possibility of EC degradation. And it has got a capacity to provide free calcium ions and may encourage the synthesis of apatite and trigger odontoblastic differentiation. The other silicate-based cement is biodendine. It is a tricalcium-based cement with a high compressive and flexural strength. And it has got a pH which exerts the lethal antibacterial effect due to the protein denaturation and damage to the DNA and cell cytoplasm. Tiracal is a calcium silicate cement modified with a hydrophilic resin. It allows to interact in the humid environments and has sustained precipitation of calcium and hydroxide over time. Ceramirs, it's a luting agent made of calcium aluminate cement, and it is of two cements, glass ionomer cement and calcium aluminate, and it aids in the luting of high-strength all zirconia and alumina crowns, prefabricated metal and cast pins and cores, gold inlays and onlays, and permanent crowns and the fixed partial dentures. And what are the bioactive materials? Bioactive composite. It releases fluoride, calcium, and phosphate to promote remineralization. It prevents secondary caries. It releases fluoride ions from fluorapatite depending on the residual crystals similar to GIC. And the utilization of the fluoride includes a classical ion-based crystallization concept. And it also promotes the formation and remineralization, which helps to seal the margins and thereby reducing the postoperative sensitivity. So what do you call as a smart restorative materials? a material that is said to be smart if it can support the remaining tooth structure to the extent that cavity preparation can be carried out in the most conservative way. These materials have a property which may be altered in a controlled fashion by stimulus such as stress, temperature, pH, electric and magnetic field. So again, there is something called as a smart composite, which is light-activated, alkaline, nano-filled glass enamel restorative material. It releases calcium and fluoride and hydroxyl ions when the intraoral pH drops below the critical pH of 5.5. So this counters the demineralization of the tooth surface. It aids in remineralization, and it can be adequately cooled in bulk thickness of up to 4 millimeter. Smart ceramics. So most of the ceramics now we are doing is zirconia. But the problem with the zirconia is it treats the opposing tooth and it treats the adjacent teeth. That is, it treats the contact. So whenever you use a zirconia crown in the posterior, if you don't recall the patient every 6 months to adjust the occlusion, there will be an increased wear in the opposing tooth and the adjacent tooth. So there is a 3 times more wear of antagonist and the adjacent teeth. So now they have introduced something called as a PEEK, that is polyethyl ketone, which is a polymer with an increased mechanical strength, increased aesthetics, minimal abrasion, and better stress modulation. Smart glass enamel cement, suggested by Davidson, ability of gel structure to absorb and release solvent rapidly in response of a stimulus. And these smart ionomer mimic the behavior of human dentine. And another smart restorative material is the self-healing dental composite. It's an advanced dental material designed to autonomously repair micro cracks that form during or after composite hardens into the dental cavity. These composites are made with conventional dental composite and with 2 additional ingredients. So one is a healing powder, which contains strontium fibroaluminosilicate particles, and there is also a healing liquid, which is nothing but an aqueous solution of polyacrylic acid encapsulated within the silica microcapsules. So whenever there is a microcrack which develops on the tooth, they break the microcapsules, releasing the healing liquid, which reacts with the healing powder to form an insoluble product that fills and seals the crack. So this is a self-healing pictorial representation of the self-healing dental composite. Crack forms and water comes in. A microcapsule is broken due to the crack propagation. And there is an ionic cross-linking. So another new material is hydrogel. So materials like metals, bioceramics, and polymers only form a stable mechanical and chemical properties, but it is far from the property is far from the natural tissue. So hydrogel, when combined with the composite in presence of bioactive molecules, form a material which is superior in tissue regeneration. So these are the clinical scenarios. A representative of the mandibular second premolar, preoperative photograph, postoperative digital bite wing radiograph, prepared cavity after selective caries excavation, and finished composite restoration. A representative of the mandibular second premolar after 3 years. A representative of the mandibular second premolar showing preoperative radiograph, finished composite restoration. And a representative of the mandibular second premolar after 3 years, and the bite wing. And this is a clinical scenario with no pathological findings related to the composite restoration underlined with. So what are the challenges faced in this material process? There are regulatory barriers because we need strict approval process which delay the availability of the new biomaterials, high cost, and there is lack of clinical evidence, and most of the materials are highly technique sensitive, and most of the clinicians may prefer traditional materials due to its familiarity. So what are the future directions? Smart biomaterials, development of materials that respond to the environmental stimuli examples pH and temperature for enhanced functionality, AI-derived research, accelerated discovery of new biomaterials through machine learning and computational modeling, regenerative dentistry, combining biomaterials with stem cell therapy and growth factors for complete tissue regeneration, 3D printing, and development of eco-friendly biomaterials with minimum environmental impact. So new research is underway to understand the complex interplay between the extracellular matrix properties, cell differentiation, and angiogenesis. Materials with native antibacterial, antimicrobial characteristics could effectively deter the formation of microbial biofilms, not through indiscriminate killing but via selective colonization. It's also likely that these new materials contain sensor molecules or compounds that monitor events occurring at margins. And new ceramics will have high strength, but be highly aesthetic and translucent. And these materials will be fabricated chairside by additive manufacturing materials using a full digital clinical workflow that will also incorporate computer-controlled ion implantation techniques. So what's the role of AI in advancing these biomaterials? The material designs. AI algorithms can predict material properties and optimize formulations for specific applications. AI can make a clinical decision making. AI-powered tools can assist the dentist in clinical decision making, quality control, data analysis, and personalized dentistry. AI can enable the design of a patient-specific restoration using 3D printing and digital workflows. So, conclusion, biomaterials and technological developments have propelled amazing improvements in the area of restorative dentistry. The range of alternatives accessible to the doctors has substantially grown, ranging from bio-inert materials that provide mechanical strength and biocompatibility to bioactive materials that promote tissue adhesion and regeneration, and bioresorbable materials that facilitate natural healing process. These innovations in the material science have marked the beginning of a new era in the biosmart dentistry. So I end the presentation by quoting, "We used to think of biomaterials as a passive substances, but the future is in materials that can talk to cells." So thank you for patient hearing. I thank the organizers for giving me an opportunity. Especially, I thank the principal of Katangulathur Dental College, Dr. Vivek, and the organizing person, orthodontist, Dr. Deepak, for giving me an opportunity to come and present in this August gathering. Thank you so much.
Thank you, Dr. Anil, for an insightful lecture in the innovation biomaterials and restorative dentistry. And we also understanding the biomaterials prior to the treatment planning helps you in the success of the treatment of all the dental restorations. Thank you, sir. Thank you for your lecture.
Now, I would like our chairperson to felicitate our guest speaker, Dr. Anil Kumar, sir.
சென்டருக்கு போயிடும். ஓகே, அங்கே போய் அந்த ஆண்டாகிறாங்க. கொஞ்சம் சென்டர்லேயே நினைச்சேன். அவங்க நிற்கிறாங்க. நீங்கள் போய் நின்றுங்க. ஓகே, நீங்கள் போய் நின்றுட்டு அவங்க நடந்து வரட்டும்.
Thank you so much, sir. Let's now invite Dr. Tamil Selvan, sir, for his next lecture.
Thank you. Our next speaker for the morning session is Dr. Tamil Selvan. He is the professor and head of oral pathology and the dean of Sri Ramachandra Institute of Higher Education and Research Center. He has a lead in practice in Ananagar, doing general dentistry in 1993, and has a training in lasers and implant dentistry. He is also executive committee member of IAOMP, International Association of Oral Medicine and Pathology, honorary secretary Tamil Nadu and Pondicherry Oral Pathology Study Group, and section editor of IGADR. So today he will be speaking to us on AI in oral pathology. Over to you, sir.
On. Respected Tanvir and my dear friend and adjunct Professor to Ramchandra, Dr. Rohan, it's indeed a great pleasure in standing in front of two legends here. Hi all, this is Dr. Tamilchelvan standing in front of you. So honored and humbled to talk about this AI in the field of dentistry. Like you all, I never knew what is this AI, but I always have a passion about learning about dentistry because I'm passionate about history. I love history, Indian history, and any leaders, I love it. So what do I talk about the history? Let me talk about my university from Sri Ramchandra Dental College. I've been working there from 1995, standing proudly in front of you as a member of ISDR and IADR, and also a dean of Sri Ramchandra Dental College. And I have my friends here. Thank you. I have my friends, Dr. Deepak, who is the organizing secretary here, and Dr. Vivek, Dr. Sundar, my classmate, Dr. Mahesh, who was also staff of Ramchandra, was the vice principal here, Dr. Anil, and many good friends here. So what is this topic about AI is, when dentistry started, it was usually no anesthesia was given. They used to make it very raw, and people thought dental care is nothing but it came from worms. Even now you see the books you see textbooks or videos from Pakistan and India, they put some solution, take some worms and saying that dental care is a come up. Are we in the right stage? No. The dentistry started from the ages. When you walk into Egypt, I've been to Egypt, I've seen the Pharaoh's museum. There was one king who had died because of osteomyelitis, which had occurred in So now we are in a phase where we can go ahead. Suspa was the father of medicine, who was also a plastic surgeon, and he has wrote a lot of literature about dentistry. So why is this dentistry is very important modern era? When you don't update yourself, you are a half-baked man. That's what I believe. You have to keep on updating yourself. So this artificial intelligence came into my mind about a couple of years when I took over the HOD post in 2019. You're forced to see slides every day. Every day you have to see about 10, 15 slides and keep on pulling your hair, which I don't have right now, wondering, what is this slide? One day I thought, a day should come, where should I keep this slide? In front of my microscope, and that microscope should have a system connected, and it should give a report, what is that? That is where my journey started here. So let me talk about my journey here. You talk to any patient, sir, you have a problem. He in front of us, he will Google immediately, start using the machine learning there, and find out what is your symptom, he'll start teaching us. Doctor, why don't you do this treatment, that treatment? And we really have to wonder whether he's correct or wrong. When we studied, when we had a pharmacology doubt, we used to have a book called SIMS. We have to go with and check it. But now Google solves all this problem. Are we going in a correct direction? So normally we have all this search engine optimization. I'm going to talk in detail. I think we had few speakers, Dr. Bhuvaneshwari and Dr. Anil, who spoke also about Anil. Let me put very simple, what is this AI? A kid who is born at a very small age will not be able to identify between a cat and a dog. It says only meow or bow bow. But how will the kid understand what is a cow or a bull or a dog or a cat? So that is the situation AI comes in. So constantly a mother or a parent will start telling the kid, this is dog, this is dog, this is dog, this is cat. a cat has this, a dog has this. So like this, AI is nothing, it's that all you have to do is keep as much as data to the keep on holding it. So this will take up the learning there. The machine takes up the learning. It goes for a deep learning, then comes the product. I will go in detail about this. This picture shows you on the left is a cat, and you localize there, you crop it, and feed it to the machine saying this is the cat. Then you have a group picture, they'll identify which is thing. For example, you go to your Google Pictures. If I put the Google Photos, I type Dr. Sundarraj, I'll be getting all hundreds of picture of Sundarraj, which was taken about 10 years back till your phone memory was there. This is the AI in the phone. And we also have a AI in the voice note, Alexa. You tell Alexa, do this, it'll do exactly whatever you want. So what is AI exactly is a big confusion because I had a journey of how my AI started. So when I didn't know what is this system, I had a situation that what is this? Then had my discussion with my niece. My favorite hero always in day-to-day life is Steve Jobs. When Steve Jobs wanted to do a computer, he didn't have an idea what to do it. He sat with his father, who was a mechanic, in a garage. He had no money, with his friend, who also was a partner of Apple in future. These three people sat together. Idea was brought together. So in that way, I sat with these few IIT professors, telling my ideas, what is this? Then only I learned there's one term called artificial intelligence in the year 2020. Till then, I never knew what is artificial intelligence. So this is all history, starts about 1950 itself people started, but it took me almost 70 years to find out what is artificial intelligence because we were never taught in our school or in colleges about what is artificial intelligence. Because we dentists, we always run away from computer and gadgets thinking that it is not up to mark. No, it is not a situation. As a person, you have to keep on learning what is new in subject. Any successful person will always keep away from the routine things and identify those things and keep pushing it here. I'll put very shortly what is this artificial intelligence. Very, very simple. Artificial intelligence is nothing but you have to keep on feeding lots of pictures and lots of data, keep loading it, and you go to a place called black box. This is called a place called black area or a black box. It is nothing but it's like a neurons. It's complete but lot of dots. It is almost like a brains where you constantly keep feeding the data, and after some time it knows what to identify. There you have this output data, and based on this output data, your treatment plan and prognosis can be made. I can give an example. For example, you have a brain tumor. When you have a brain tumor in MRI, will say that you have a brain tumor. But a study in McKinsey University, what's happening is one Indian, a lady, has found that using artificial intelligence in MRI, it is called as MRAI. MRAI can identify whether this tumor is a benign or malignant so that you can avoid unnecessary surgery. Otherwise, imagine you have to open the skull and take the tumor out and find out whether it's a benign or malignant. So this is how AI works. Let me go walk into the few slides how this AI expects in medicine. Number one, it can predict the diagnosis of a disease, which I'm going to talk in oral pathology. And medical image diagnosis, we have a concept called Zebra, where the moment you take radiological picture, it can diagnose it and can give the treatment planning. So, and maybe in another 10, 15 years, if I'm not wrong, the field of radiologists, the field of pathologists might vanish very slowly. Maybe there'll be one guy who will be monitoring the AI machines. Otherwise, the moment it takes radiology pictures, the treatment plan and diagnosis will just pop in matter of seconds. And you also have drug discovery. We have personalized medicine, your medical robots and clinical trials. I'm not going to concentrate on that. This is the machine I've told you. The moment you take CT scan, the treatment prognosis and treatment plan is out, so that you need not wait for the diagnosis to be made by the radiologist. But this is going to be the future. And already you have an Embrace watch, which is used for epilepsy patient. And you also have an AI software in Apple phone, where it constantly monitors your ECG and it sends signals or it says when you have a problem. We should be very proud. Google have tied up with Arvind Eye Hospital, and it is screening about lakhs and lakhs of retina and heart disease patients. And another 5-6 years, a ophthalmologist or a cardiologist can predict when will you getting heart disease in a matter of years. The days are very close by. So this is what I told you. It's called Zebra Medical Vision. The moment you take X-rays or the CT scan or MRI, it will find out what is your problem and the treatment plan is made up here. So Google right now, it's collaborating with using the artificial intelligence to find out what will your problem in another 10 years. AI in dentistry, it helps in making diagnosis, prognosis, and decision making. So this is about introduction about AI. Now we're going to talk about my journey in oral pathology, in oral cancer diagnosis. It's very sad to say that India is a highly thickly populated with tobacco diseases, and there are few cases where we see patients with no tobacco lesions also. Why this oral cancer is so high is, number one, it is because of tobacco usage, and number two is of food habits, and number three is of sharp teeth margin has become a problem, and fourth is unawareness. The dentists themselves are not aware how to detect oral cancer. The days are not very far away where a machine started making diagnosis here. So this is the very oral cancer, very pathetic here. Every third person or fourth person are likely to get cancer in any part of the body, and every person, third woman in this hall can have a cancer in their life. So the problem with this, these cancers are not detected at a very early stage except for extraorally and intraorally. Otherwise, whichever is in your body, it's very difficult to find out. And even if they find out, we have a problem in making a radiological diagnosis because you have to rely on the pathologist. A pathologist is a field of people who take a tissue and put it in the processing, in the microscope, we make a diagnosis. The problem is the moment you take a biopsy, these patients have a problem. They have to wait for 4-5 days to make a diagnosis. Is it easy to give a report? No. The surgeons will accept. We have a problem because we have a lot of complex diseases happening. So these patients need one more study called as immunohistochemistry, which has a panel of markers which may also not lead to a problem things. So AI will come into this picture. Trust me, in another 10-15 years or decade, AI can make all these diagnoses very soon. The only problem is the data collection is happening. So we need not wait for even biopsy. I'll tell you how this journey is going right now here. So this is about this all highest incidence in India in oral cancer, and most common females are very much affected. And A in oral cancer is, this is few X-rays. And what we do is you take a picture. This is the slide here. The moment you take an oral tissue, we go for a whole body scan, whole image scanner. These image scanners are captured and stored in the cloud. And at the same time, the clinical pictures are also taken. My journey in Ramchana is we have screened almost 1,000 squamous cell carcinoma patients, and we are taking these pictures as a whole body scanner, and we have taken almost 20,000 pictures. We have loaded them to the computer also, and radiological images also. We have an oral cancer clinic. So any cancer cases reported to our college will be taken to these clinics. A complete history is noted. So history is noted, clinical picture is loaded, histopathological picture is loaded, and radiological picture is loaded. And these will all be these will be extracted. So this machine is now taught. For example, in one study, we have a study where we have taken about 1,000 slides of squamous cell carcinoma, and these slides are loaded into the machine. Now, the machine is learning. The machine is in the process of learning what is normal tissue, what is mitosis, what is dysplasia, what is DNA, which is color black, which is blue. So the machine is right now learning very much. On the top, this is called a machine learning process, which we cannot do it. It's only a bioinformatics department can work on this. And now the machine will go for a deep learning. Next is the machine is trained. Now it has to keep learning more and it can make predictions. Is this AI accurate? Yes. 90% right now it's accurate. The more data it gets fed, the more accurate it make it. So this is what I'm trying to say here. You have input of all these pictures. The future is extracted and goes for a machine learning and deep learning, finally comes to the output. These are the few cases which we see in our department. You can see that the whole body, the whole image is scanned on the left. Now the machine is learning. We also load the mucosal machine. So now the machine have learned what is mucosal. The moment you keep the slide of mucosal under microscope, it can give a diagnosis of microscope in 0.05 seconds. Same way, this whole image is scanned and now it predicts. So now the machine knows, okay, this is a area which I have to work because this is how it has been taught. The teaching the machine is done by the humankind here. Once it comes here, now it will come to an output. It says, okay, listen, Tamil, this is a high risk. Tamil, this is the medium risk. Tamil, this is the... It can give the diagnosis. How long will it take? In few seconds. Whereas we pathologists will take not less than 4 to 5 days to give a tough cases of reporting because we need immunohistochemistry marker here. So this is from University of Malay where we have a tie-up. They have come with a mobile app. This mobile app, anybody in Malaysia can download the app. They can take a pic of them and this pic reaches to their oral surgeon or oral pathologist where they can make diagnosis here. It is also used in the OMPD. This is the study what right now we are doing in our institute. All we do is we take about 1,000 cases of OMPDs, gets reported. Pictures, we take about 25 pictures of each patient and all these pictures are loaded in the system and whole body slide is being done here. And right now we have sent to the machine. The machine is right now learning. And we also have doing a study on pemphigus vulgaris. You all know that pemphigus vulgaris has a dark field. You see a slide here. You have an acantholytic cells, a eosinophil. This is the major criteria here. Now, this machine is right now learning here, which is an acantholytic cell, which is an eosinophil here, which is a multinucleated cell. So the machine right now with all multiple dots all interconnected, it's like a brain. So now these neurons are being fed by the machine here. So this is the histopathology database. So once you load, this is the normal. You take a 100x normal and this is OACC. Now we both compare it and right now sending machine. The logarithm, what we have it is, this is how it shows this. This is how the machine learns there on the left. This is for the normal slide and this is for the slide here. These are the few logarithms which we ourselves are learning for bioinformatics because they are more trained at here. These are the few progresses here. So our journey started about 5 years with absolute no idea what is AI, but we are still in a process of learning and machine is also learning. What has happened? Why are you shouting so loudly, Tamil? Yes, hard work never fails. What has happened is right. With a small study, what we did was, Indian government has sanctioned 84 lakhs to our institute, where we've taken about 1,000 slides of squamous cell carcinoma. And I'm proud to say that when this comes, the moment you put a slide under the microscope, it makes a diagnosis of SCC, which will be 99% accurate. Need not take time, no need to go for immunohistochemistry, no need of markers. It will just save the time of patient because I think Tanvir will accept taking a biopsy. You keep calling us for 7 days, patient gets panic. You give it, the days will come. If you put an image, not even biopsy is required. It will come with diagnosis here. We have one more project called MIDAS. This is sanctioned along with AIMS, where we have collecting about 20,000 images we have collected from the patients. And these data are being loaded. And we have about 9 centers all over India. So this is a medical imaging data sets for tobacco-induced lesion. The moment the picture is loaded, it can make a diagnosis, whether it's a leukoplakia or erythroplakia or SCC or it's a normal tissue. So this will save unnecessary moment of time. So this is the team from our institute. This is the team for the institute working behind us. And we also had, it is a gadget we receive for taking photography is very important because photography is very important because machine doesn't know anything. We have to tell the machine, this is the situation, do it, things are done here. And this is our team with a normal microscope. Trust me, another 10 years, this microscope will vanish. So the take-home message is feed. Feed the machine. Don't hesitate if somebody is asking for the database because we dentists are here to save the patient. The more data you give, the machine will learn more and the things will better. Right now, the accuracy of AI is 90%. There's an argument going on whether the machine will make mistake or not. Same thing happened about 20 years back. They were telling the implant was a failure, laser is a failure. But right now, the world is situated with implants and lasers. So another 15 years, AI is going to rule the world. So I think without knowing the knowledge of AI, we'll go half-baked man. Artificial intelligence will be a future. Human intelligence is always superior than artificial intelligence. But to keep the control of AI, we should be the master of AI. That is very important. And always push to the best version of yourself because Google Lens is watching you. Thank you so much for this wonderful opportunity. I take a big opportunity to thank Dr. Anil Kole, who is my mentor, and Dr. S.M. Balaji, who's always Rajinikanth in field of dentistry, whom I used to admire. And this is Dr. Tamil signing off. Love you all. God bless you. Wish you all the very best. Thank you for the opportunity. Thank you, chairpersons.
Thank you very much, Professor Tamil Chalvan, for that excellent presentation, as well as finished well within the time. As we have a little bit of a time, we can entertain a question or two if there is any.
Yeah, I'll be happy if there are any questions, but I'm also in learning phase. But I can always extend hand. You can reach out my mail ID or my mobile number, which is available in Google. Thank you, sir. I think there are no takers.
Thank you very much.
So thank you, sir, for a mind-blogging presentation. And all your data's input that you give into your computer, I hope it graduates soon. And it also does its master graduates. And also, maybe I'll even call you as the Steve Jobs of the oral pathology. It's coming up in the making. Thank you, sir. Thank you.
Thank you, sir. Now I would like to call upon our chairperson to felicitate our speaker. Now I would like to call upon Dr. Sundaraj sir to come up on the stage and felicitate our chairperson. Now, I would like to call upon our next chairperson, Dr. Gaurav Mishra, Professor of Public Health Dentistry in King George Medical University, and Dr. Sybil, Professor and Head in Department of Public Health Dentistry, to be the chairperson.
Censoring it. Thank you. Center stage. Okay. Screen. Up, down, this one. Change. Yeah, you can change that.
I would like to call our next speaker, Dr. Tanveer sir, and request our chairperson to introduce our guest speaker.
Moving now.
So, sir is currently the professor and head of Department of Oral and Maxillofacial Surgery and principal of CSI College of Dental Sciences. His field of interest are trauma and minor oral surgery. Sir, please continue.
So very good morning to you all. So today's topic is on the translation of research to oral and maxillofacial surgery with particular interest to oral surgery because I see a lot of young graduates here. So I thought I should get some message or give some message for them so that they can practice oral surgery or they can incorporate research advancements in their practice as soon as they graduate and they start their clinical practice here on. So, yeah, it's going. So the research in oral and maxillofacial surgery has been happening in a lot of areas, especially in the areas of diagnosis, regeneration, treatment planning, therapy, and also teaching and learning. So I'd like to highlight some of the points that had been discussed earlier by Dr. Tamilchelvan. He had given a beautiful insight into the diagnosis part of oral cancers. So there is a device that has come up with immunofluorescence, where there is a green light. When you just focus the green light inside the oral cavity, it's going to catch up areas of pre-malignant lesions or precancerous lesions, and that can be diagnosed easily in a mass screening or a camp or even in your clinical practice. So these kind of technology advancements are happening and it can be incorporated in your practice. So this works by means of spectroscopy, and this is just like fluorophosphates that happens in the oral cavity. When you start focusing these lights, this fluorophosphates activates the lining of the stroma, and it again gives areas of demarcation of darker and greener so that you can diagnose precancerous or pre-malignant lesions. So a lot of things that we learn today, and one of the things is that regeneration of tissues. This regeneration of tissues happens has come up with a long way, but nowadays the superstar should be of these PRP and PRFs. This PRP and PRF or IPRF or TPRFs has seen its application in various areas of periodontal dentistry. So initially it started with bone losses and other things. Then slowly we started advancing, and it had got great research, and a lot of things happened in the development of this field. And it also finds its place in oral and maxillofacial surgery. For an undergraduate perspective, I'd like to tell that if you're going to extract a tooth, so you want to preserve the ridge, you can use this PRF or TPRF to these kind of sockets. So it has the architecture of the socket, and if you're going to plan for implants in future, this is going to help a lot. So restoration of the socket is maintained. You have the preservation of soft tissues and hard tissues, and it's also convenient for you to place an implant. So instead of just closing the socket or compressing the socket or put some gauze and cotton, you can also try to these kind of innovations so that future, when you're going to put an implant, it will be very helpful. Also, for a smaller surgical point of view, you can incorporate this PRF in your day-to-day clinical practice. Like if there is any small case of, this is a case, the first one is a case of focus sclerosing osteomyelitis. The patient was having paresthesia, so the curettage was done in the local anesthesia, and we used PRF in this area. So after a period of 1 year, we were surprised to see that the entire healing process has happened, and even the patient had reversal of this paresthesia and numbness was coming down. And also, we also use this PRF in this vestibuloplasty and pre-prosthetic surgery areas. And we also found that after a period of 1 or 1.5 years, there are remarkable results. And it's also very helpful for the prosthodontist to go for the next level of denture or implants. So the same PRF can be used for filling of cavities or bone supplements. If there is any small cyst, we had a case of small cyst in the mandible. In a pediatric case, we enucleated the cyst and we tried to pack with this PRF. And after a time of a year, we were so satisfied to see that particular area was regenerating with a lot of bones and other natural materials instead of leaving a large gap. So we were able to see there is a regeneration happening and it's also mimicking the nature. So some larger cysts like amyloblastoma can also be tried by this application of this PRF. So instead of resection of the mandible, this patient was quite a young man. So he doesn't want to lose his mandible at the age of 30 or 35. So we tried PRF and it also gave us a positive result. So when we made an volumetric analysis of the area after a period of 1 year, so we were even satisfied to put an implant at that particular place. So dental implants, we know titanium implants are there, but nowadays a new generation of implants have come. They are called as ceramic implants. So these ceramic implants are metal-free, less mucosal discoloration. It also biocompatible, and the major thing is it's non-allergic. The reason behind invention of the ceramic implants is because some of the patients, say 0.6 number of patients, are allergic to titanium. So this titanium metal has an alternative like a ceramic implant. So you can use these ceramic implants in patients who are more prone for allergic reactions. The only thing is that the flexibility part of this ceramic implants has yet to be developed. And also, the inflammatory process around the implant is less when compared to the titanium. And the manufacturing cost is also quite expensive, and the indication is also less. So there are some smart implants coming up, like what Dr. Tamilcharan told. So the implant coating and the implant surfaces are developing day by day, so we can prevent the peri-implantitis and bone loss and other things happening around the implants. So in future, you can even get feedback from the implants. What is the status of the implant? How is it functioning? Is there any other thing happening around the implants? All these things can be understood with the small chip in the implant. So this is the development that is going to happen in future. And the targeted therapy in the management of TMJ disorders, already things have come up and it's already in the market. So this photobiomodulation technique aids the doctor instead of having an invasive procedure in an initial case of TMJ disorders or TMD disorders can be managed with these kind of photobiomodulation techniques. So a lot of studies have come up with the photobiomodulation and its effect and its cure in the TMD disorders. And for an alveolar osteitis, usually we see routine cases of alveolar osteitis or dry socket. So these dry sockets can be managed by means of medical techniques, as well as you can use these kind of lasers to remove the bacterial effect in the socket so that the healing takes place faster and the patient is comfortable without any pain. So these are some of the things that you can incorporate in your practice. And also, a newer drug delivering system has come up. So if you want to deliver a drug continuously or a continuous drug delivering system, you can incorporate the drug in the denture itself. So the denture is going to release the drug, or sustained release of the drug is going to happen. And at the same time, it doesn't need to remind the patient of applying the drug or any treatment protocol frequently. So these kind of things are catching up, and it's going to be the future of dentistry. And of course, this word you're going to hear more than 100 times today, because dentistry is evolving, it's going to change, it's changing, and each time a lot of things are learned, deep learning, and artificial intelligence and machine learning. So all these things are catching up. Even in oral and maxillofacial surgical field, a lot of developments of AI has come up, starting from diagnosis, treatment plan, detection, imaging, and planning. So, and finally, there are areas that that newer innovations and technologies have come up. And the most interesting areas are for the students are this teaching and learning. So we have this virtual VR device. So with this device, we were able to give a lot of informations, and you can train the surgeon, new surgeon, and also it gives a guidance to the surgeon. And it also plans the treatment and also improves the patient's education, and it's very accurate. And finally, it is a potential growing area where you can teach the students beyond the classrooms. And the next area of innovation and technology in oral surgery is that these are robotic arms. It's called as haptic arms. So you don't need to actually, when you want to do an impaction surgery or extraction, or even you put a plate and screw for a fracture. So you can have a modulation or module even before doing on an actual patient or training a lab, where you have certain devices. It's something like where you take your car to the garage for your wheel balancing. So whenever you do a wheel balancing, there are 4 sensors attached to the tire, and that gives a data to the CPU computer, and you align the wheel. Similarly, when you do an implant, there are some attachments that you put in your handpieces. So when you guide the handpiece to the particular place, it gives a green signal. That's the ideal place to place an implant, and you go down to the actual desired place. So things are learning up. As a young graduates, what we would like to tell you is keep on learning, keep on training, and ultimately it's going to be a scientific world, and a lot of things is going to change. To catch up with that, we have to learn. So that is the take-home message, and thank you one and all.
Thank you, Dr. Tanvir. A very excellent presentation on how we can traverse further with the help of research into clinical and oral surgical practice, because without going deep into research, we cannot think of the future advancements in oral surgical practices in our daily life, and as well as our all the doctors sitting here, they also must be agree with that. So thank you very much, Dr. Tanvir. Have a good day.
Thank you, sir. Now I would like to request our chairperson to felicitate Dr. Tanvir, sir. Now I would like to call upon our next guest speaker, Dr. Arpit Gupta, for his lecture. And I would request our chairperson to introduce Dr. Arpit Gupta.
So I'm very happy to invite the guest speaker for this session, Dr. Arpit Gupta, Associate Professor, Oral Health and Science Center, PGI Chandigarh. So beyond that, sir is a very well-known public health dentist in the country with numerous credentials to his profile. And also he works very closely with the ministry in a number of activities or oral health activities, to be specific. And this forum is all yours, sir. Over to you.
Thank you so much, respected chair. And it is indeed an honor to be standing before you. And all thanks to the board members of ICD, Dr. Deepak, the dignitaries from SRM, and all of you, you being here, listening to this talk. So I hope I am audible. Yeah. I hope I am audible. Yeah. So for next half an hour, we would be discussing something about xerostomia, something about radiation-induced xerostomia. And this very presentation is an outcome of our learnings for last 2 years that we have been running a preventive dentistry clinic at PGI Chandigarh. So it is kind of a unique clinic whereby we deal with adult preventive dentistry. And it being a medical institute, a premier institute of the country, we have been looking at a lot of patients who are scheduled or planned for radiotherapy, and they are being sent to the preventive dentistry clinic for dental clearances and so on. So, radiation-induced xerostomia. Is it really a very rare kind of a thing? Radiation-induced xerostomia? Just an important thing to understand. But if we look at these statistics from India, that every year almost 2.5 lakh patients are diagnosed with head and neck cancers. So now these head and neck cancers are of various types, may it be lip and oral cavity, the hypopharynx, salivary gland, larynx, oropharynx, and nasopharynx. But one thing very common for all these head and neck cancer is that almost 80 to 90% of these patients are being subjected to radiotherapy, because radiotherapy is a cornerstone of management of head and neck cancers. Now, if we talk about radiotherapy, radiotherapy, as you all know, I mean, the oral tissues or the tissues of head and neck use that mic. Not better. Okay, I think it's better now. Okay, so radiotherapy, if we understand, the oral tissues are subjected to some radiations, and that radiation has got indeed harmful effect on the oral cavity. And this radiation affects the salivary gland. How do they affect the salivary gland? They lead to cellular damage. There is some free radicals which are released, which lead to cellular damage. It leads to fibrosis of the blood vessels. So there is reduced blood supply, and there is inflammation and atrophy of the salivary glands. Now, the question is, why are these salivary glands more vulnerable to radiotherapy? A simple thing is, as we all know, that salivary gland has got acinar cells, which are secretory in nature. So these cells are more vulnerable to the radiations. Then they have limited regenerative capacity. It has a very rich vascular network and a very high water content. So these are the reasons why the salivary glands are more vulnerable to the radiation. And ultimately, it leads to what we know as xerostomia. Now, this xerostomia looks like a very simple thing to understand, but it reduces the quality of life of an individual to a very poor one. So that's the biggest challenge with xerostomia. Clinically, the tongue looks like bald or glassy appearance. And a simple way to understand is the mouth mirror. The mouth mirror sticks. The moment you run the mouth mirror into the oral cavity, the mirror sticks into the buccal mucosa or to the tongue. So it happens. The salivation is very low, very poor. The normal cleansing of oral cavity, it doesn't really happen because salivation is very poor. The saliva is thick, or in many cases, there is no saliva at all, or it is frothy. And the patient complains of, difficulty in speaking, difficulty in chewing, masticating. And these are cases which will present to you with a very poor quality of life. So, important factors, when we talk about radiation-induced xerostomia, things start right before radiation therapy itself. So, some factors to be considered for the impact of radiation on salivary functions are the total dose of radiation. High doses means there is high chance of having a radiation-induced xerostomia. Whether radiation is unilateral or bilateral, extent of the upper aerodigestive tract included in the field, and there are certain advanced technologies like IMRT, which is intensity modulated radiotherapy or volumetric modulated arc radiotherapy, which are used nowadays to prevent, or let's say to spare some of these glands from the effect of radiation. But again, they have got limited effect. End of the day, it is the patient's intrinsic response to radiotherapy which matters. But whatever we do, there is some amount of xerostomia which is going to set in. Now the question is, can we prevent xerostomia? Yes, to a limited extent. And what do we do to prevent xerostomia? One is there are some pharmacological interventions like pilocarpine. You must have read about pilocarpine maybe in your oral medicine classes. So pilocarpine is used, and amifostine is used these days. It is in now. And there are some other techniques like parotid sparing technique, which I just talked about, IMRT and VMRT. And there are some submandibular gland sparing techniques. But what happens, once this xerostomia has set in? Patient is reporting to you that I have undergone radiotherapy and now it is xerostomia which is there. So what are the treatment options which are available? So we have some conventional drugs like pilocarpine I have just talked about. There are some more to it. We have some cellulytics which includes N-acetylcysteine. So these are some conventional ways of managing radiation-induced xerostomia. We have some salivary substitutes, which we kind of give conventionally, some lubricating properties, moisturizing properties, and all. Some hydration techniques, we ask the patient to drink more water or keep sipping water again and again at very short intervals. So these are some techniques which are used. Then there are some gustatory stimulants, and the newer techniques. And then these newer techniques, the most important what we are going to talk about is TENS. So, but why do we need these newer techniques? Because the conventional techniques have got various limitations. And some of the limitations are that none of the conventional technique is long lasting. If it is pilocarpine, it is very short lasting. It doesn't last for long. If it is like salivary substitutes, it is, the patient has to be on those substitutes regularly, very frequently. The patient has to keep sipping water, keep spraying his mouth with artificial saliva before every meal, but the quality of life is very difficult, it's very poor in such patients. Therefore, these newer modalities, specifically TENS, is kind of something which is being explored these days, and it is one of the promising non-invasive approaches in which stimulates, it stimulates the nerve endings in enhancing the salivary flow through these glands. The simple mechanism of action is that it releases some electrical stimuli, and there is electrodes which are placed on these glands, and these stimuli, they increases the salivary reflex arc and stimulates the salivary flow, and there is some relief to the dry mouth. Advantages of TENS include it is superior to pilocarpine. We have certain studies which I'll be just discussing about how TENS is better than pilocarpine. It has no chemical activity. It is only electrical stimulation of the salivary gland. So there is no chemical activity. We are preventing a lot of toxic effects or adverse effects of pilocarpine. Then it is non-invasive. There are few contraindications, and it can be easily incorporated into clinical and home settings as well. If we talk about standard care, TENS doesn't really work alone. There is standard care which go hand in hand with TENS, which includes adequate hydration levels, instruction for proper oral hygiene to the patient, and encourage to visit routine dental checkups. There are certain parameters which we have to preset and predetermine before starting using TENS, which include which gland is to be stimulated, whether it is about parotid gland or submandibular gland or both the glands. Then type of TENS technique. So we'll be talking about a few of the techniques. So we have to determine which type of technique we are entitled to use, the frequency and intensity of the stimulating current, the type, size, and placement of stimulating electrodes, the frequency and duration of stimulation session to be provided for clinical improvement. We have kind of delved into the evidence, we have delved into the literature and seen the evidence related to TENS, which says that largely the TENS can be classified into three various modalities. One is the conventional TENS, whereby we give low intensity stimulation, which has high frequency. Then we have acupuncture related TENS. It can be related to a needle or it can be related to a surface electrode, whereby high intensity stimulation is given and it generally has a very low frequency. And then we have intense TENS. So this is relatively an advanced version of intense TENS, whereby we give high intensity stimulation and high frequency. So this is a basic understanding of the types of TENS. Looking at the summary of evidence. Now, believe it or not, TENS looks very simple, but we just have 5 studies which are existing in the literature as far as TENS is concerned. Only 5 studies. Out of these 5 studies, we have 3 RCTs and 2 intervention trials. And the part is that all these trials are using various methods of delivering TENS. So there is no common theme, and we are still unaware that which is the best modality or which is the best module or which machine is to be used or which at which intensity, what's the best intensity to be used. So we have varied studies, only 5 existing in the literature. But one thing is common. If we look at the conclusion of all these studies, they are pointing out to a direction which says either TENS is as good as pilocarpine, which means we are preventing on to many adverse effects of pilocarpine, or some studies are saying that TENS is better than pilocarpine in managing radiation-induced xerostomia. So I think that's the most important take-home message. 2 things. One is we are in a dearth of literature as far as TENS is concerned. So to all the young fertile minds, especially the postgraduates and the undergraduates as well, it needs a lot of research to be done on TENS. And to others who are dealing with such patients of radiation-induced xerostomia, maybe at your clinic or at your hospitals, it is worth exploring TENS. This is just one of the research which we are undertaking at our institute. This is a trial which is ongoing. So very briefly, it has 3 arms, whereby we are recruiting 25 patients in each arm. In the first arm, we are subjecting patients to TENS therapy. In the second arm, 2% pilocarpine. And the third arm is the conventional therapy, whereby we are just asking patients to increase the hydration, keep sipping more water, or use some salivary substitute like saliva and all. So these 3 arms we are trying to compare. So the initial results are very promising, and believe it or not, TENS is doing wonders as compared to pilocarpine. So these are our some initial findings of this study. What we are doing, what protocol we are using at PGI is very simple. We are placing surface electrodes over the parotid region and the submandibular region, and we are using a fixed pulse rate of 50 hertz. And we are using an optimal intensity, and we are increasing the intensity until and unless the patient is tolerable. Because once the intensity is too much, there is some tingling sensation which starts up. So until and unless it is safely tolerable to the patient, we keep increasing the intensity. In the initial sessions, we have seen the tolerance is less. But in the later sessions, patients are able to tolerate more and more of the intensity. And we are generally giving 2 sessions every week for 20 minutes per session for a period of 3 months. So that's the broad regime which we are following at our institute. There are some researches on customized TENS as well, some customized devices based on the sizes. And the best part is it enables patients to use these devices even at home, because we have seen in some of the literature has said that even after 3 months, the saliva rate increases, but few months down the line, it again starts subsiding. So in those patients, in those cases, we can very well prescribe the in-home usage of TENS to these patients, and there are some custom-designed TENS as well. So it gives, the biggest challenge is where to place the electrode. So we can teach the patient, or we can use this custom-designed TENS as well. So just to end with that, xerostomia may be an unavoidable condition during the management of head and neck cancers. And believe it, again, I repeat that the number is huge. Every year in our country, there are 2.5 lakh, more than 2.5 lakh patients of head and neck cancers. So the xerostomia in these patients is almost 80 to 90%, which is huge. And the quality of life deteriorates to a very low level once this xerostomia sets in. So the TENS is one of the promising modalities to restore saliva production in these patients. And there is a dearth of literature. We are still not able to find the optimal TENS technique. The parameters remains unclear due to inconsistencies in the literature, which calls for more research on this topic. I think that's it from my side. Thank you so much. Thank you.
Thank you, Dr. Arpit Gupta, for such an interesting insight into the TENS therapy. And we think with the increasing incidence of oral cancer, such non-invasive techniques are the need of the hour. And we really congratulate PGI Chandigarh for exploring into such areas. Thank you, sir.
Thank you. Do we have some questions? Okay. Okay, please. Thank you so much.
Any questions? I think if you want further details on how the research on TENS is happening, you can also DM Dr. Arpit Gupta. Thank you.
Thank you, sir. I would like to call upon our chairperson to felicitate our speaker. Now I would like to call upon Dr. Kavita ma'am to felicitate our chairperson. Now, I would like to invite our next chairperson, Dr. Vijay Adit sir, Professor and Head, Priyadarshini Dental College, and Dr. Ruban sir, Professor Ragas Dental College, Department of Oral Pathology, to chair our next guest lecture. Now, I would like to invite our next guest speaker, Dr. Arunima ma'am, and request our chairperson to introduce the speaker.
Good morning. It is my pleasure to introduce Dr. Arunima, periodontist and dental researcher at PMS Dental College in Trivandrum, with over 15 years of experience and more than 40 articles under her feather. She has received the Excellence in Dental Research Award at ISDR, and she has also won the Best Scientific Presentation Award at the AIMST International Dental Conference in 2021. I would welcome you onto the stage, ma'am. The stage is yours. She'll be here in a couple of minutes, yeah.
Since Arunima ma'am is running a bit late, we have Balaji sir. For our next lecture, I would like our chairperson to introduce sir.
Of course, it is indeed an honor and a pleasure to have you here, sir. Dr. K. Balaji, one of the renowned orthodontists and a teacher of sort for all the upcoming orthodontists who want to learn aligners. He's the go-to man. He's been having a clinical practice for more than 24 years now. He has a special interest in TMJ and a very, very special interest in invisible orthodontic treatment. His aligner courses, sell like hotcakes. Everybody wants to be there at Balaji sir's clinic and learn a lot about aligners. He's the head of the department at Tagore Dental College and Hospital, and he's also the past treasurer of Indian Orthodontic Society. And a special mention should go about all his courses on in-nose aligners. He's a fantastic teacher in that. It's really a pleasure to have you here, sir.
Thank you.
Hope you're ready. The stage is yours, sir.
Yes. In 2 minutes. How do I put this one? Just put this on. I don't know how to do this. Praveen is the man. Thank you. Check. Yeah. Okay, a very good morning to all present here. Thank you, Vijay, for that introduction. Thank you. I'm happy that I'm at my friend's college who is heading the department, and the principal of the college is my school senior. So it's great being here to talk in front of the fellow dentists. That's a little bit of me. Today's topic is going to be on treatment of complex orthodontic cases with in-office aligners. So I am Dr. Balaji, as introduced, former treasurer, former EC member, and in-office aligner practitioner, and that's my email and my Insta and my phone number if you have any doubts, right? So all of the dentist would be very eagerly practicing or wanting to know about aligners. And the word is synonymous. Invisalign and aligners are synonymous. And many companies are doing aligners, and many companies approach the dentist to do aligners. So in-office aligners are different from the company aligners. So the company has got a base, and they have some technicians or orthodontists working for them. Morning, sir. Orthodontics working for them who make the aligners for the purpose for moving the teeth as an orthodontic work like. Okay? So then there are so many companies which are doing aligners. Why should we, as doctors or orthodontists, especially orthodontists, should do in-office aligners? And if at all dentists want to practice aligners, is it important to I mean, how important it is to have an orthodontist to do aligners. So let's see first why orthodontists are important for aligner treatment. Okay? Why orthodontists are important, right? So, many of the today companies are not reliable, okay? Because many of these small dental labs in, I don't want to say states, in the southern states or the northern states are giving aligners to everyone. And most of them don't have trained orthodontists to give aligners, right? And these companies don't have any research like the bigger companies, the international companies, the bigger international companies. So what they are trying to do is do in-office aligners and give it to you. And orthodontists, many of them are not using orthodontists to provide treatment with aligners. The second thing is, what looks very, very nice is their digital plan. The digital plan promise is not getting converted to reality. What they show you, you won't get it in the patient's mouth. So that's where the company aligners are not reliable, like the in-office aligners. Orthodontists today are available in plenty. Most of the colleges, there are post-graduation in orthodontics, right? So they are there, they are available in plenty, and they are not expensive. So make use of them for doing your aligners. The most important thing to do aligners are to learn biomechanics. You should have a basic understanding of biomechanics of tooth movement, okay, which is absolute necessity to move the teeth with aligners. And who has this training? 3 years of training is there for the orthodontist to learn biomechanics, okay? The CAD software, which is used for making aligners, okay, requires special training, and the software looks very rosy to operate. But to convert whatever you have planned in the software to the patient outcome, we need complete biomechanics. What I have seen in few of the labs which I've come across, what they do is technicians work. So they don't even know the envelope of discrepancy. They just intrude the tooth more than 2 mm, 3 mm, and they give rotations 30, 40 degrees within 5 aligners. Within 5 aligners, how can you rotate a teeth when the periodontium is only 0.2 mm, right? So when you do all these things, what are the problems you end up with? Here is a video I have of a patient during my initial days when I did not know biomechanics of aligners. What you're seeing here is a relapse case, okay? A relapse case where there is spacing there on the upper and the lower arches. So I'm closing the spaces and I'm intruding the upper teeth. I did not know the right way to do it because I've not learned properly. So I'm closing the spaces on the plan. This is the digital plan or a simulation which we give to our patients for them to visualize, which looks very rosy. The teeth got intruded and the spaces got closed. Everything looked very nice. And that's before and that's after. Quite reasonable. It looks reasonable. But we had given around 20 sets of aligners, and that's how we ended up with. Spaces got closed, but look at the bite. I have dumped it because I did not know the software properly. I did not know the aligners properly. How does it look? And that is what we should have got, and what we got was this improper planning. This is what is happening with many of the companies. What you will end up with, TMJ issues. Forget about dentists doing aligners. We have now direct to consumer aligners. There are so many companies which are doing it. I got a call through my Insta, somebody reached me. I got a call, Doc, will you come home and take a scan? Will you come home and give me an aligner? I said, you need to come here. In return, what I say, no, I want somebody to come home. That's where we are today, right? So this is what DIY aligners, do it yourself or direct to consumer aligners. Thanks to DCI, which has put a full stop to it, but still people are practicing this sort of a thing, behind the scenes, right? There were so many companies in the US. Now, if you see, most of the companies are going bankrupt because patients don't want to go to companies, don't want to go to companies directly and get aligners. They want the orthodontist to give the aligners, right? So this is more important, that an orthodontist does the aligners, okay? As dentists, yes, you can practice aligners, simple cases, yes, but with a statutory warning, under the guidance of an orthodontist. Ask your orthodontist, there is nothing wrong. This simple case I'm going to do, it's a removable appliance, if it is safe or not. What looked simple in the earlier case, I complicated it by giving a wrong plan. This is what most of the companies are doing. So with that little bit of insight, who has to practice aligners? Let's go into the history of aligners. So H.T. Kessling, tooth positioner, way back in 1945, was the first aligner given. It was like the protective thing in the mouth, which used to be worn, which is made out of silica, and that single piece became a double piece by orthodontist and was made by plastic. Okay, Nahum, Ponitz, McNamara, and Sheridan modified all these Kessling's approach, and today's aligners are all based on the researches of these orthodontists, and that we get today's aligners. Okay, so it is contrary to the fact that the newer company like Invisalign and all did not invent the aligners, and even there is a debate going on in US that why did they give patency to Invisalign, right? So because it is a product of orthodontic treatment. It is not something new which they discovered. They put in some efforts which we are going to say. Now, how do these aligners work? So all of us at some point of a time, as a final year BDS or as a orthodontist, we know Kessling setup. What is this Kessling setup? So Kessling setup is nothing but you have a problem like crowding, or you have especially crowding, let's say, or space closure. What we do is we make use of jeweler's saw or a rotatory sort of a disc, or use some sort of a machinery to cut the teeth at the mesiodistally. As you can see here, they are cutting it with a disc, a jeweler's saw, right, and repositioning them on the wax, and then over that and plastic sheet was thermoformed with the help of a mini star. So let's say you have a space like a diastema between the two teeth and you want to close it. You slowly move the teeth. 0.2 mm is the periodontal space. That much you use for each movement, and then you close the space. So you'll have multiple models. And on those multiple models, you thermoform sheets, and those are given as aligners to the patient. So it is a laborious process in the past. Okay, so how do the teeth move? The teeth move by shape molding effect, molding the target teeth according to the shape of the aligner used. Pre-established mismatches between the aligner shape and dental crown geometry generate 3D force systems. There are areas of intimate contact and relief between the aligner. A full treatment consists of set of aligners with sequentially varying shapes. So this is how it was done. But as you know, cutting, making 10 models and cutting them is all laborious process. So how to simplify this? That is where Zia Chisti and Kelsey Worth, who are the founders of Invisalign, came in. What they did was, they knew that the CAT software and a 3D model or a 3D impression of the teeth was good enough to make these multiple models. But then, how to print these multiple models or how to make these multiple models? So 3D printer was the choice to make this multiple models. So when you combine Kessling setup, 3D scanning, and the CAT software and the 3D printer, the today's aligners were born. Okay? So with that little bit, let's see what is in-office aligners and its workflow. So what do you do in in-office aligners? First, you identify the patient. Then what you do is take the records. Records are not like the regular records like a FA. You can go for an OPG and then impression. A digital impression would be more appropriate than going in for a manual, a non-digital impression. Once you make an impression, then take it to the CAD software and then work on the treatment planning. So you plan the treatment, whatever the final position of the teeth. So you're going to plan in the treatment plan, and the plan gives you export. That is, your models can be exported. 20 models, 30 models, 10 models are exported, and then you can outsource it to an aligner lab for aligners to be produced, just like your crowns, where you do a crown preparation, take a digital impression, send it to the lab, and the lab gives you the crowns. Same way you can get the aligners by giving the files, STL files we call it, right? Or you can set up your own lab and then do the manufacturing all by yourself. You get your aligners. Now, which are the cases which, as a dentist, you can do by yourself? A simple crowding, a simple spacing case. Now look at this case. It's a simple case where you have spacing between the teeth, and this patient is periodontally compromised as well. We did a flap surgery before we started the treatment, right? And that is what we did. If you can notice, I have given attachments only in the front teeth, right? There are no attachments on the back teeth. Unlike regular aligners, which requires attachment in the posterior teeth to anchor the aligners, I have not given anything here. You may wonder why. Will the aligner sit properly? This is a new material, direct printed aligner, which is called as Graphy, which we use. So that aligners don't require anchoring attachments. Without that itself, the aligners stay in the oral cavity very well. So that's what was being used, and that's the pre-treatment, and that is the digital plan, okay, which was shown to the patient. Now look at the speed of the treatment. So here you see space with the aligner, Graphy, and then space closure slowly, and we have got the final result. How many aligners? 8 aligners. How many days they used the aligner? Every month was 2 aligners being used, or even less we can use. 3 aligners also could be used. So within a matter of 3 to 4 months, I've closed the space. Patient is happy. You are happy. We are all happy at the end of the day. So using the correct treating the correct patient is what you will, the road to success for the dentist as such, right? So what is the difference between fixed appliance and clear aligners? How do this work? So here you can see force. Fixed appliance exerts a pull force on the teeth, whereas clear aligner produces a push force. Engagement, arch wire into the bracket. The thicker the wire, the better the engagement. Plastic around the teeth. The more plastic wrapped around the teeth, the better the engagement. Here, anchorage segments may be predetermined. So with this, let's jump into my cases, which I have treated, complex cases, which I am treating, and I am treated with aligners. So my experience with the aligners will go in. So what are the complex cases? So you saw the simple case, like a spacing or a crowding. What we call as complex cases are, you have molar distalization, extraction cases, then moderate to severe crowding cases, deep bite cases, open bite cases, and cross bite cases. So these are complex cases which we call, right? And when we use aligners alone, okay, so they are an conventional aligner therapy. But when we add something to the aligner, then it becomes a hybrid therapy. For example, if you add even an elastic, like a class 2, class 3 elastic, it becomes a hybrid therapy. If you're going to add tats, it becomes a hybrid therapy. Or you want to start with a fixed appliance and then go to aligners, then it becomes a hybrid therapy. So a hybrid therapy is something which you add on with the aligners, right? So let's see first molar distalization case of my patient, what I have done. For molar distalization, what are the things you should follow? Non-extraction cases, okay? So non-extraction cases, maxillary molar distalization, you can gain up to 2 to 3 mm, okay? So then obtained through staging and vertical rectangular attachments and class 2 elastics, long vertical attachments, okay, oppose the tipping movement, all right, and increase in posterior anchorage while retracting the aligners. So what are the things which are needed? You need to have rectangular attachments on the posteriors when you're distalizing, and you need to stage your movement. That is, it is called as sequential distalization. You cannot move all the teeth together. You multi-rooted teeth, like the second molar has to be moved first, then the first molar, and then premolar, etc. Right? So when you involve less tooth, your output is good. So these are the things. The rectangular attachments on the posterior teeth are very, very important to prevent tipping. We need bodily movement. For all this, maxillary molar distalization, these are the things which you use. Class 2 elastics use. That is mandatory. So suppose if you are going to do distalization in a class 3 case, then it is class 3 elastics, and in a class 2 case, it will be a class 2 elastic. So elastic wear right from the start of the treatment is important. Full-time usage is recommended. Average period is about 8.5 months, right? Correction is usually dentoalveolar. For dental discrepancy between 3 and 5, you can use proximal stripping and molar rotation. If it is greater than 5, go for extraction. So we are going to concentrate on only distalization, right? So estimated time is approximately 30 months. So whenever you are performing a distalization, don't make false promises to the patient that my treatment duration is going to be reduced. Your treatment duration will be similar to FA. So the main advantage of aligner is that we are going to do treatment in a short duration. It's not so. You're going to have a longer duration of treatment with distalization, right? So then, change of aligners. So whenever you are doing multi-rooted teeth like a molar, you do a 2-week change. And for the premolars, you can do a 10 days change. And when we are doing the anterior movement, you do a 7-day change, right? So this is how you have to plan your distalization. CAD software predictions in most of the cases will require above 60 aligners. Now what I'm going to show you, I had done it in 80 aligners. So here is a patient. You can see there is a reverse overjet, and anteriorly there is a class 3 in the posterior segment. And here the patient within 10 aligners had the bite opened, right? So if you see here, within a period of about almost 30 aligners usage, we have got movement from here to here. You can see around 3 mm the molar has moved, right? So we have distalized the molar 3 mm, the lower molar. The same way on the left side also. How we were able to do it? With class 3 elastics, I hope you can see the class 3 elastics. This is called as precision cut, and that is called as a button. So from the button to the precision cut, we have given tooth-colored elastics. Many of them use colored elastics. There are tooth-colored elastics available. So I've used that to do the correction. This is the present stage of this patient. So I am settling down the posteriors. You can see a class 3 patient with reverse overjet, and we have done distalization, right? So that is sequential distalization for you. Complex case, the second situation are extraction cases, moderate to severe crowding cases, deep bite cases. All in one, I have a patient, but before that, let us see what are the things you should do when you are handling when you are doing aligners for extraction cases. Extraction spaces are closed with the aligners. When you are closing without attachment or elastics, there is going to be bowing effect of the canine and the premolar. It will bow in. So it will be tipping into that because of the plastic, right? So plastic getting into the way. So you need to prevent that from happening. How do you prevent? You put attachments on either side, and then if you want, just go back to our Beck mechanics. We give a class 2 elastics. So you give a class 2 elastic from the canine to the lower molar so that you will get a distalizing movement very well. All right? Elastics attached directly to an aligner, however, the plastic will separate. So put a button on the canine, all right? And then direct bonded hooks should be attached to the upper canine, right? Attach elastics in the mandibular arch, which serves as an anchorage. And then finally, vertical rectangular attachments on the mesial edges of the molars. Molars prevented the mesial angulation of the molar when you are giving elastics. So that's how you plan up, okay? So there are 5 things to be planned out. One is a button cut for the molar, lower molar, rectangular attachments. Then you have a button here for direct bonded hook for the elastic engagement. Then your elastics, rectangular attachments, and the bondable button on the molar. So these 5 things you have to strictly follow when you are doing an extraction case. When you want to correct deep bite, all right? Deep bite correction, unlike FAs, fixed appliance, you can start correcting the reed bite right from day one. What do we do in deep bite in FA cases? So we start with upper arch. Slowly we go to the lower arch, right? When adequate opening we can put in the bracket. Nothing like that here. Right from day one, you can start your bite correction. So how bite correction is achieved? Mostly, okay, we intrude the incisor and canine on the occlusal edges of the teeth and pressure on the lingual side, okay? When you plan extrusion, right, of the posteriors, don't plan at 0.2. 0.2 is the periodontal ligament space. Don't plan at that. We need at least extrusion of 0.15 mm per stage should be planned. So when you're extruding the posterior. Curve-free correction. How do you do the curve-free correction? You have to use a frog protocol. That is, you have to vary your intrusion of the anteriors. First, you intrude the canines followed by the incisors. So it will be a relative intrusion where you procline the lower also, right? So this is how we correct the deep bite, right? So what are the things, how do you plan up for correcting the deep bite, right? Decide intrusion of the anterior teeth. Adequate anchorage should be provided in the molar and the premolar region. So how do you provide anchorage? With giving a gingival beveled attachment, rectangular beveled attachment, horizontal rectangular beveled attachment, and frog protocol. How does frog protocol work? Let's see. So here is a chart of how frog protocol works. Here, the tooth is there. This is staging. You stage the movement. First, you stage the movement of the posteriors along with the canines. Then you stage the movement of the incisors and then alternate it. So here you have the tooth numbers, and this is where attachments goes in and comes out. So if you see here, first what we are doing, we are extruding the posteriors. 7 and the 6 are extruded. At the same time, we are intruding the canines. Can you see that? And we are extruding the posteriors. So why do we not intrude all the teeth together. Too many elements and too many forces, you will have problem with the aligners. It's a removable appliance, for God's sake. So you don't add lot of teeth with lot of movement, right? So that is why we are following a frog protocol, okay? So here, there is continuation of extrusion of the posteriors. Now the incisors are getting intruded. We are staging the intrusion of the incisors and we have stopped the canine. So alternate canine, and then after 5 aligners, it is the incisors. How many aligners will require? More than 60 aligners. Don't expect this also to get completed within 6 months, 8 months, like how I have told you. Simple cases will get over, but not these sort of cases. And what are the days where? 7 days where. Here is my case. Okay, we have some, it's a class 1 with a lot of crowding. The incisor are in a class 2, division 2 position, right? So you have a lot of crowding in the lower and the upper anteriors. We had planned to go in for extraction of the upper force and the lower force, right? So what we have done? So we have started moving. You can see the dumping of the incisors happening. These were our initial days, so we were not very thorough with our attachments. So we dumped the anteriors, but the spaces are closing. So that's a photograph with the aligners. And look at how we have corrected the crowding anteriors. Upper lower anterior crowding corrected, and we required some extra help for correcting the dumping or the deep bite. So what did we do? We put couple of tads and we intruded the anteriors, right? And you can see here, we have intruded, we have more or less made the incisor straight, right? So from here to here, from here to here. And this whole treatment completed in about 18 months. So you're looking at 1.5 years with some help with the TADs. We have done this. So we have corrected the crowding. We have got good incisor relationship. And of course, the molars on one side needed a little bit of settling, and that was done with the retainers also, right? So this is how you plan your extraction cases, deep bite cases. So this is extraction, deep bite, and crowding cases you have to plan. There are other crowding cases which you can plan with IPR, but I am not having time to show these cases. So I am limiting myself with one case for all the 3 together, right? The next is open bite cases. How you are going to manage open bite? One of the most difficult movement with aligners are your open bite. So for open bite, okay, open bite correction, extrusion of incisors should be planned. If you're going to extrude, okay, you need attachments to extrude. The attachment should be horizontal beveled attachments, okay? Beveling should be occlusal. Then only you will get that shutter effect to pull the teeth from above down, okay? And the posteriors require intrusion. So remember, we are giving aligners. Aligners have an occlusal coverage of plastic. So that occlusal coverage of plastic already has got an action to intrude the posteriors, bite block effect. Along with that, if you want, you can add up some occlusal bite turbos, or if you want sequential intrusion, you can do a sequential intrusion as well for open bite correction, right? So skipping that, I've already told all about this. So sometimes you need to add up a TAD if you want to intrude more than 1 mm. So how much, you may ask? Molar intrusion, 0.5 to 1 mm is what is possible without implants or without help. So here is a patient with anterior open bite with spacing. So we had planned treatment. So that's his lateral cephalogram and his OPG. And here's the patient with aligners. If you can see our attachments, I'm just finishing, 2 minutes. You can see our attachments are not exactly what I had told you. We had given rectangular. These were our initial stages, but we managed to correct the open bite, and we managed to correct the this thing, what we call it as a drawbridge effect. We were able to do that. So this is of like open bite correction though it's difficult, but easily manageable with our aligners. Next is crossbite. I'm just going to show you a case of crossbite, what we have done. Okay, here is a case of crossbite. So you can see here on the right side, we have given a bite turbos to open up the bite, lingual bite turbos to open up the bite, right? And this is within 6 to 8 months, we got this result where the crossbite got corrected and we had to settle down the posteriors. So what we did was we gave some elastics. Those were the days we didn't have tooth-colored elastics, so we gave cross elastics, the elastics to settle down the posterior along with the aligners, but we were not happy. So we switched over to Graphy. So this is the present, this is not the present condition. So from here to here, and this is the present condition where we have given Graphy aligners, the direct printed aligners, which promises more results in the case of crossbites. So that's the present state of the patient. We have closed the spaces in the bottom and we are trying to settle down the posteriors. Without elastics, we are settling it down. No implants, no extra things except for attachments. Now we are settling it down with only horizontal attachments, pulling the teeth down. And we managed a lot. Probably in another 2-3 months, we'll be getting more results and I'll be able to show you. So here on the left side, right side, and that is on the left side. So this is the frontal pictures, that's the lower picture. And if you can see, the OPG images are there. The present OPG image I don't have, but you can see how well we have closed the space as well. So with that, this is one of my nicely finished student case where we started as an open bite and we gave aligners, normal aligners within about 6 months. This is the end of 3 months, 8 aligners, and that's the finish after 5 months we have given. So this is not a complex case, I showed you that we can give good finish with aligners as well. But only thing is, you need to understand the biomechanics and start working on it, right? So cases, what you should avoid is active periodontal disease, multiple missing teeth, initially I'm talking about, okay? Short clinical crowns, of course, today short clinical crowns can be easily managed with DPA, direct printed aligners, severe parafunction, severe COCR discrepancy. And of course, if you want to learn aligner, we run courses for the orthodontist, only orthodontist. So anytime you can contact me. I have a video, but I'm not going to play that. We are running short of time. So with that little, that's how you can reach me. I'm there on Insta, and that's my email and my mobile number. So anytime you are free to raise any questions to me, I'll be more than happy to share knowledge and answer your questions as well. Thank you for a patient listening.
Thank you, dear Balaji sir, for that awesome presentation.
Thank you.
As always, substantiated with the work done by you and your wonderful team.
Thank you.
I
Thank
hope
you.
all the audience had a sneak peek in how much amount of hard work goes behind fabricating and delivering the aligners.
Yes.
And thank you so much for the wonderful presentation.
Thank you. Yeah, done. Yeah. Yeah. Go on. Yeah. Is there a switch here? You can speak in this. Just speak in the mic there.
Thank you so much, sir. Now I would like to request our chairperson to felicitate Dr. Balaji, sir.
Yeah. Take a photograph of somebody. Right stage.
Now, I would like to call upon our next speaker, Dr. Arunima ma'am, and also request our chairperson to introduce Dr. Arunima ma'am.
Yeah, I think it's one more opportunity again to introduce Arunima ma'am. Arunima ma'am again. Welcome, ma'am. As I said earlier, she's a periodontist and dental researcher at PMS Dental College in Trivandrum. With over 15 years of experience and more than 40 articles under her feather, she has also received the Excellence in Dental Research Award at ISDR and also won the Best Scientific Presentation Award at the AIMST International Dental Conference in 2021. Welcome, ma'am. The stage is yours.
Thank you, sir, for your wonderful introduction. Good afternoon, ladies and gentlemen. Warm greetings from my college, PMS College of Dental Science and Research. And we are one of the knowledge partner for this conference. Before I commence on my topic, let me give a brief introduction about tissue engineering. The idea of tissue engineering started almost 30 years back. The famous work by Joseph Vacanti and Robert Langer, where they have experimented a ear mouse, which is nothing, a biodegradable polymer, which they have seeded cartilage cells and they have implanted into the mouse, the back of the mouse. And they have observed for a period of time, and they could find that the research was really successful and it creates a really buzz in the field of regenerative medicine. And that's how the fascinating world of regenerative medicines began. As you all know, from hematology to tissue engineering, this is yet another fascinating area of research where hemostasis and coagulation science in a synergistic collaborative work with tissue engineering leads to the regenerative dentistry. That means even in dentistry, we need repair and regeneration, and you can depend on hematology. And the idea of tissue engineering concepts from hematology began even years back, approximately in the year 1954, and one of the landmark work published entitled The Evidence of an Antagonistic to Factor 6 in the Platelet-Rich Human Plasma, and the work was done by Karl Marx and Kingsley. And the basic rationale for using the platelet concentrate is that this particular material, the concentrates, possess supraphysiological dose of growth factors that are responsible for tissue regeneration, which is derived from the autologous source. And it is not new. We all know that biomaterials can be obtained from human origin. And now we have, as per the slides, you can see that we harvest tissue graft, extracellular matrix constituents, decellularized extracellular matrix constituents, and finally, you can have a combination of cell culture materials or stem cells incorporated into the biomaterial scaffolds. And one of the most popular and widely used autologous material being the autologous platelet concentrates. Sorry. Sorry. And as you see in the slide, that the work on platelet concentrates began in 1954, and we still continue the research on this platelet concentrates, and the latest being the bio-PRF. I'll come into the detail of each platelet concentrates in the later slides. And the objective of my presentation being, does platelet concentrates fulfill the criteria of tissue engineering concepts? With that in mind, the topic of my presentation is platelet concentrates, the pinnacle of biomimicry. The contents of my presentation is divided into 3 sessions. Mainly the first session, we'll cover up with the platelet concentrates, highlighting the platelet-rich fibrin variants. And the second is the factors influencing the preparation protocols of platelet-rich fibrin. And the last session being how the evidence-based research have influenced the clinical application of platelet-rich fibrin. As you all know, platelets is a multifaceted cell. It has a very good role in the regulation of vascular tone. It regulates the immune function, hemostasis, mitogenesis, angiogenesis, and it plays a very important role in tissue regeneration. That means the regenerative potential of platelets is mainly focused on 3 aspects: angiogenesis, and it supports the cell migration, proliferation, and differentiation, and it even supports the production of collagen. And it's just a brief overview. There are many classifications for platelet concentrates, and even the latest being put forward by 2019 by Chu et al. But still we follow a very simple classification, like, you can put the platelet concentrates in 4 generations. The first generation, which is nothing, the PRP and its derivatives. Second generation, platelet-rich fibrin. And the third being the variants of PRF, the modifications in the centrifugation protocol of PRF. And the 4th generation being the platelet concentrates coupled with growth factors or stem cells. So, as mentioned before, these are all the biological effects of platelet concentrates. It helps in mainly tissue tissue repair and tissue regeneration. So, moving on to the first generation of platelet concentrates, the PRP, which is popularly used 20 years back, and I think the research work was mainly focused on the PRP work. And later on, they understood that the additives which is used for PRP preparations, like the bovine thrombin, which causes coagulopathies, and they withdraw the use of PRP for a while. And later on, nowadays, we have the application of PRP in dentistry is very much limited, but the external use like hair transplantation or for cosmetic uses, still we rely on the support of PRP, and we have several chairside kits to do the process. And the second generation, the PRF, which is widely used basically because of the simple methodology we use. We don't need to add any biochemical additives. It's just a single spin centrifugation. I'll show you a slide, the difference between these 2, first generation and second generation. And because of this, even in dentistry, in all branches of dentistry, we use PRF in one or the other form. And this is the basic difference between PRP and PRF. PRP is that, as I mentioned, it's the addition of bovine thrombin, and you need to prepare calcium chloride, which you need the support of a biochemist to proportionate the level of calcium chloride up to 10%. And then you have to add it onto the blood, and you have to do for a 2-spin centrifugation. But you will get a rigid network. And it was quite commonly used in oral and maxillofacial surgery years back, and you do have a resistant gel. But as you compare the PRP with PRF, as I mentioned, it is a single spin procedure. You don't need any additives, and you will get a flexible fibrin network. That's the disadvantage of PRF, and it is very much an elastic gel. These are all the variants of PRF variants, which I'm moving on to the 3rd generation of PRF, platelet concentrates. And you can see a wide variety, like the standard leukocyte PRF, You have the APRF, advanced PRF, you have the injectable PRF, and you have the autologous fibrin glue, which is mainly used for the preparation of sticky bone. And now comes the concept of low-speed centrifugation. That how the PRF or the third generation of PRF came to begin. The usual, the centrifugation. When I come to the last topic, the centrifugation protocol, I'll make you understand how does the centrifugation protocol affects the preparation of PRF, which is nothing. They have reduced the G forces. That means the initial preparation of PRF, we have used around 800 plus or like 1000 plus 8 grams of milligrams or the RCF force to prepare the PRF, as well as the RPM, the revolution per minute. That was also high. And what happened to that was, you will get a material of a good quality, it can withstand the mechanical properties, but the cellular property was very much compromised, or the bioactivity of the material was very much compromised. That's why they have put forward the concept of low-speed centrifugation concept, and the first one being the advanced platelet-rich fibrin, and the second one, now we commonly use that one in practice, is the injectable PRF. Again, injectable PRF also, they have formulated two protocols, one with 700 RPM for 4 minutes, another one is, again, with that time variation, they have come to like 700 RPM for 5 minutes. And they studied that nowadays, we have one more PRF available. That means, again, from 4 minutes, they have reduced one more minute and made it to 700 RPM to 3 minutes. That is the right protocol we are following now. And you have a device to prepare the sticky bone. To prepare the sticky bone, we use the support of injectable PRF, which you can insert this equipment or a small device into the test tube, and you can, you can do up this spin and later on remove the spin and you can add the bone graft and then again do a second round spin. You will get a material that is the sticky bone. This is the first patent device to prepare the sticky bone. This is how the preparation of sticky bone. You will get the autologous fibrin glue. You can mix it with the biomaterial of your choice and keep it for 5 to 10 minutes. The polymerization will get initiated, and then you'll get a material like this where the bone graft is incorporated into the polymerized matrix. And when you come to the extended PRF, the disadvantage of the conventional platelet-rich concentrate is that, the survivability of the material, that means biodegradability of the material, it resorbs fast. Another problem is that the material or the fibrin material or structure is very thin to withstand the forces. So for which we have, come forward with, the researchers have come forward with the different formulations of PRF to extend the resorption time. And one among is the PRF lysate. The second one, concentrated PRF, which is widely used in endodontics. And the third one, the latest being the bio-PRF. This is a lyophilized PRF, one protocol where they have dried the PRF material and they have powdered and they stored it for a while. And then they have mixed it with the injectable PRF at the time of use. And this is one of my study which I have done was, I have prepared a lyophilized aloe vera matrix. And in that aloe vera matrix, I have incorporated injectable PRF just to know whether that injectable PRF will contain active platelets or not. And this is a SEM study which I could find out that, the 3 different time duration, I could find out the last picture which shows the active platelets in the matrix. So coming to the albumin PRF or the bio-PRF, or you otherwise call it as BioBone, this is the latest technology whereby which you will obtain it by a 2-spin method, and it is basically the rationale for using this bio-PRF is nothing. You can prolong the viability of PRF and you can use it, and they have found out that the resorption time has extended up to 4 to 6 months, and which is very much needed in the field of implantology or a ridge augmentation procedure or a sinus augmentation procedure, where they have separated the platelet poor plasma first, and then they have centrifuged and separated the leukocyte PRF, and then they have heated the material up to around 75 degrees Celsius, and that you call it as a bioheating. And then they have cooled the material, biocooling, and then they have used or mixed it with the initial PPP, the platelet poor plasma, and they have stored it. And you can mix it even with the biomaterial, or you can mix it with any biomaterial, and the product you call it as a biobone. And you need a separate centrifuge for the preparation of this biobone. And this centrifuge picture, this is the first commercially available horizontal centrifuge machine, which is specifically designed for the preparation of bio-PRF. So this is what I've mentioned, that is, the existing PRF protocols, be it leukocyte PRF, or when they come to the latest preparation, bio-PRF, you can add any material onto it. You can add a peptide, you can add a stem cells, and you can create a better scaffold. Depends upon the need. So when I talk about the application of platelet concentrates in dentistry, this is one living biomaterial which is having a wide application in all the fields of dentistry. And these are the few cases which is done in my department, where, this is a case of grade 2 furcation management, which was indicated, grade 3 furcation management, which was indicated for root resection. Resected the root, we have placed bone material or bio-os, and then we have covered the bone graft with the PRF membrane, and you can see the pre and the post radiograph. And then we have used the same PRF material for periapical lesions. And even you can use it for phenotype modification, where the biotype of the gingiva is very thin. You can use injectable PRF, and you need certain intervals. You have to recall the patient and do the protocols, and you can, thereby which you can improve the biotype of the gingiva. And you can use PRF blocks like sticky bone for ridge augmentation. And we can use this platelet-rich fibrin for gingival recession management. You call that as a fibrin-assisted soft tissue promotion techniques. So when I discuss about the evidence-based reviews, this is one material which is, we all started using it, but the researchers started later on, because whenever we prepare a material or a biomaterial for our use, we synthesize, and then we do the characterization. It goes for a phases, clinical trials, and then only it comes to the market. But this being an autologous product, we all have used with the notion that we don't have any side effects. It's true. But how important is its bioactivity is still compromised. Many researchers, the researchers started very late onto this material. So when we talk about the research, we move on to the concepts of 6 levels of evidence of platelet concentrates. And the researchers have concluded that both PRP and PRF, still when we compare the randomized control trial or systematic review, the conclusion remains heterogeneous. There are so much of bias involved. There are no standardization of the protocols. So there are to explore the important aspects regarding the evidence-based review. I'm just putting up the important studies to conclude. So do autologous platelet concentrates have a role in intraoral bone regeneration? They have compared, and they have concluded that LPRF, which is the first designed LPRF by Chokuran, and that material have better mechanical properties but less bioactivity. But lots of studies have been conducted on LPRF, and they've concluded that among the PRF variants, the data for LPRF is most convincing. And even the studies by Richard Mirren, which is one of the great personality who have worked on maximum work on platelet concentrate, especially PRF, and they have concluded that around 87% studies have supported the use of PRF for soft tissue regeneration and wound healing. This is a very important aspects which most of us doesn't have much idea about it. I just want to highlight few things here. We all know, like, if you have a case there up, you will decide to proceed with the material preparation on any PRF. You're not thinking about whether the blood collection parameters is right or the centrifugation protocols are set appropriately and the materials pipetting, whether these factors influence the preparation or not. So when regarding PRP, the consensus report have concluded that double spin centrifugation is the best method to obtain PRP. And the additives, and among the additives, the researchers have concluded that to use the acid citrase dextrose as a preferred anticoagulant as compared to all other anticoagulant for safety concern. And again, in the PRP, regards to PRP, there are two variants like PRGFA and PRGFB. Among the two variants, they focused that better to use PRGFB variant because, it has a better regenerative potential as well as, it has a less concentrate. You can use a less concentrate of sodium citrate and calcium chloride as compared to PRF-GFA. And this is one of the study, which is my study, which is being published in Journal of Indian Society of Periodontology, and where we have compared all the variants of PRF. And what I have concluded was among the PRF, this IPRF is the best one to have a regenerative potential because it holds maximum amount of cellular activity and growth factor release as compared to all other PRF variants. And again, they have said that the blood collection parameters do influence the quality of the PRF, and they showed that, as time interval increased, you will get only looser cells and a denser and organized matrix. As the time prolongs, you will get less amount of cells and less amount of growth factors, but the polymerization happens very strongly and you will get a dense band matrix. And as compared to the storage of platelets, whether we can store the platelet concentrates or not, PRP can store up to 1 month on study by McLean. Another study, they have said that you can froze the PRP and you can use it later on. If a patient is having a multiple implant placement or if a patient has to go for ridge augmentation followed by sinus augmentation, sinus lift procedure, again, one-time drawing of the blood and you can freeze it and you can frozen the material and you can use it when the patient comes for the later time. But in the case of platelet-rich fibrin, which we all does it in our clinics, the storage time is very much compromised around 5 to 7 hours. That means if you have a case to do planned for a platelet-rich fibrin, you can draw the blood, you can do the procedure, you can do the centrifugation, prepare the material and keep, because it should not disturb the test tube at all. You can keep it for 5 to 6 hours minimum. So this is a picture which shows how the quality of PZS with time goes. Time interval, the correlation between the time interval of blood collection and centrifuge. From the picture, you can make out that, the 2 minutes, the clot has been shrinked and the cellular activity and the bioactivity will get compromised if the clot is left open. And this is a very important and the latest concept regarding centrifugal characteristics and PRF. So initially, we were using the old centrifuge where you have a fixed angle centrifuge system, where the tube will be placed in 45 to 90 degree angulation. Nowadays, that concept is slowly changing. We rely on the horizontal centrifugation protocol. And where in India, we have only 1 or 2 patent centrifuge machine which follows the horizontal centrifugation protocols. Otherwise, in abroad countries, 2 or 3 FDA-approved centrifuge machines are there, including for the bio-PRF preparation. What they say from the picture, it is very clearly, you can make out the difference that fixed angle centrifuge, you keep it for 45 to 90 degree, the tube, and what happens is that when you apply G-force, the cells will be pushed towards this, like away from the clot or away from the buffy clot. But if you keep the material or if you keep the test tube in a horizontal fashion, what happens is that the cells will get entrapped into the PRF matrix. That means, for example, if you are taking a LPRF preparation, it is very important. Correct RPM and time is only you having a moderate importance, but very much you have to give importance for the G-force and the angulation. RPM is the revolution per minute, how speed the rotator rotates, whereas the G-force is the accelerating force you apply onto the sample. That is called as RCF. So this is a picture which is demonstrating how to calculate RCF. So the centrifuge, which is already being standardized, means for horizontal centrifugation means they will set the RCF values and they will given it for use. So coming to the optimization of platelet-rich fibrin, there are study by Chokuran in the year 2080. They have concluded that use of horizontal centrifugation of PRF is opposed to the standard fixed angle device, and they have concluded that you will get the yield up to 4-fold increase in the cell concentration. And again, the optimal centrifugation speed and time for a solid PRF. If you're using a solid PRF, you go for between 400 to 700 G-force for 8 minutes. And this is yet another study published from my side, where I have compared the LPRF and APRF, and where I have studied the surface microtopography using atomic force microscopy. And I could find out the differences that, like as the centrifugation force is increased, you will get a dense fibrin matrix. That means LPRF, the centrifugation force, G-force is higher, whereas in APRF, it is less. So you can see the fibrin organization between LPRF and APRF. So with that, we'll come to a concept of AR2T3. This is a recent concept. They say that for any centrifuge, you need to have these many parameters. That means A, for angle or radius maximum, R, the relative centrifugal force, and then the next R being the revolution per minute, the T3s are there, you have to consider the time of centrifugation, tube size, and tube characteristics. So this is the AR2T3 concept, where you can go for the comparison between the vertical and horizontal PRF centrifugation. So now the concept is that if you are planning to, if you want a better yield of platelets and its bioactivity, better stick on to the use of horizontal centrifugation protocols. And this is another study. They have compared the relative centrifugal force and time. That is, increasing the RCF will accelerate the sedimentation of blood components, and you can see the position of the tubes and how does it influence the quality of the material. And again, modifying the time of centrifugation modifies the time of G-force and the blood components. So this is how, when it comes to the application, limitations of platelet concentrates in clinical application, from all the studies we can conclude that with whether the combination of PRF with any biomaterial, the best material to have a combination means that you use a autograft bone plus PRF. That stands first, followed by the DFDBA or the allogenic bone graft with the PRF. And you can see the graph comparison, which is realistic and which is ideal. So as I mentioned before, the disadvantages of platelet concentrates: faster degradation rate, inability to sustain for a long-term growth factor release, poor mechanical properties, and mismatch with the complex regenerative environment, and difficulty in maintaining a long-time structural integrity. That's why even researchers have put a pause where they cannot get data regarding the complete regeneration of or like the outcome of platelet concentrates. So the unstable positioning of PCs therapy in regenerative therapy is that from research point of view is that from all the articles which I have concluded that it performs higher performance bias because each one uses different protocols, the centrifuge methods, centrifuge differs, an unidentified and complex mechanism of action, and even meta-analysis have been performed on the data and from a poor RCT. So if you have to have a meta-analysis, to do a meta-analysis, you need to have a good quality randomized control trials. And even in clinical trials, it is not observed, like you all know that when you have to do a drug trial, you have to stick on to a proper protocols. But in the case of PRF, it is not being done. And poor or irreproducible clinical outcomes upon solo application. That means if you use PRF alone, you will not get the perfect regenerative outcome. So you can consider platelet concentrates as a adjuvant therapy, not as a solo therapy. So based on this, in future, you can modify the platelet concentrates by adding hydrogel-based concentrates. You can add nanoparticles. You can do fibrin-based products by using 3D printing or electrospinning, etc. So to conclude, and the take-home message, the science behind the preparation of platelet concentrate is still in infancy. We are far from producing the ideal platelet concentrates and using this autologous biological products to its fullest potential. So, as I mentioned before, the stand-alone platelet concentrate application has low levels of evidence, and combining platelet concentrates with biomaterial is therefore a viable synergistic strategy. I sincerely thank all the organizing committee members of ICD conference for giving me this opportunity. Special gratitude to my family, my teachers, and my dearest friends. May God bless you all, and thank you for your patient listening. Thank you all.
Thank you, ma'am. Thank you so much for enlightening us with that wonderful lecture.
Yes.
We started with PRP and we have come to AR2T3 now.
Yes.
And whenever I listen to all those alphabets, the one thing we always remember, one of my students, when I asked him what is PRF, he was like, very in a jokingly fashion, he said, "Sir, I know only ICF, which is integral coach factory, a very renowned area in this area." It's so tough, to understand the subject and the amount of research you've done on this, and to produce such a wonderful lecture, enlightening the limitations. Actually, everybody is towards PRF and PRP and the newer things. The integration is very, very important. Just PC concentrates alone is not going to be helpful.
Yes.
Thank you so much. It was
Thank you,
a
sir.
wonderful presentation.
Thank you.
Thank you.
Thank you, ma'am. Now I would like to call upon our chairperson to felicitate our speaker. Now I would like to call upon Dr. Praveen, Assistant Professor and Co-Scientific Chairman, to felicitate our chairperson. Now, I would like to call upon our new chairperson, Dr. N. Kannan and Dr. V.S. Kohli.
We are not doing more than
Now, I would request our chairperson to introduce our next speaker, Dr. Sharad Kapoor, for his next guest lecture.
Oh, I'm I don't have the pointer.
Hello. It is my privilege to introduce Dr. Sharad Kapoor, who has done his post-graduation from King George Medical College, Lucknow in 1984. Dr. Sharad Kapoor has been practicing clinical dentistry for the past 40 years and worked in premier institutions like PGI, Chandigarh, and Batra Hospital, New Delhi. Dr. Sharad Kapoor specializes in orthodontics and implant dentistry and has been practicing for the past 40 years. He has undergone advanced implant training with Dr. Tom Balshi from Philadelphia, USA, and Ophir Formovich of Alpha Bio from Israel, and has taken place in various Nobel Biocare deliberations all over the world. Without much delay, we request Dr. Sharad Kapoor sir to start his presentation. Thank you, sir.
Thank you very much. Good afternoon, friends. I bring greetings to you all from Delhi. Today morning also, when we were here early in the morning, when we started the session, we had talked about that dentistry is definitely an art and science. And keeping that art and science in our mind, we always have one focus that we should be able to provide our patients a beautiful smile. Because the importance of a beautiful smile should never be underestimated. Any type of a patient is there, they have to come down to our office and they should walk out with a beautiful smile. Because it does not only mean the physical attractiveness, but it also gives them a tremendous amount of confidence and security. Today, we are going to talk about edentulism and the treatment which is related to edentulism. When we talk about edentulism, that the missing teeth are there are always problems associated. It can be a single tooth, it can be a multiple tooth, or even it can be a complete edentulous arch. And what has been the solution for this? It is not that the solutions which were there before have become redundant. No, they still exist, but depends upon what a patient can afford and what they are ready to go in for. Till now, the treatment which has been possible with the patients has been either you give them a bridge or you give them a flipper or a complete denture. But there are multiple problems which have been associated with these prostheses, and they have been either you have to reduce the adjoining teeth, or you have to compromise the aesthetics. There can be a food lodgement underneath the crowns or the bridges. There can be soreness, looseness, and maybe the biggest important is the social acceptance of the patient to these prostheses. Now, what we have a better solution for these patients. The better and the best solution possible is, if you can really afford it, is providing them with a replacement to the natural teeth by providing them with implants. Implants are given because they preserve the healthy bone, they preserve the teeth, and even they have a 98 to 100% of success rate these days and the best option. Before we go into implant dentistry, one must always remember that you have to have a very nice, good, solid knowledge about the anatomy and the physiology, because that is the foundation on which you are going to provide your patients with the implant. And it is a prerequisite for understanding the complications. You have to understand the anatomy and physiology. And without the understanding of this, if you have any problem because of the closing structures, nearby structures, then how you handle those problems. Implants have had a journey of nearly about 70 years. And in this 70 years, we have seen a lot of transformation which has taken place in the implant. Maybe it was diagnosis or treatment planning. Whether it was armamentarium, means that the implants have undergone a tremendous change into their designs and the surgical protocols. When Professor Brennemark had brought about implants, they were only titanium implant, pure titanium. But now we have a titanium surface coated, whether it's a ti-unite or maybe any of the plasma sprayed. There have been a modification as far as the implant surfaces, just in order to increase the osseointegration capability of the implant. And even the surgical protocols have been changed over a period of time. When we started it, maybe about 30 years back, we had to wait for 3 months or 6 months of period of time to provide our patients with the prosthesis. But now you can provide the patient the prosthesis within a day. And we are still slowly heading towards AI-based diagnosis and treatment planning. Today, I am going to talk to you all about your first implant. The idea behind is that in case you all decide to go ahead with the implant, what are the things which you should carry in mind when you proceed? Let's make it as simple as possible, what we used to do and what should be the trend to be followed on. If you want to be successful into implant dentistry today, you should have a proper aim. What are you planning to achieve? And if that goal is perfectly placed into your mind, that's how you will be able to execute your surgery and get the success. So what we need is a very good diagnosis and a treatment planning. Any project has to have a very careful planning. If you miss on to the planning, the results can be disastrous. These are the two living examples right in front of us. Either we have a leaning tower of Pisa, which was really decided and it was unplanned, or we can have a Burj Khalifa there. We have had situations like these also where the implants have been placed, but it became extremely difficult to restore such teeth because the positioning of the implant was like that it was not possible to give them an aesthetic solution. So ultimately what had to be done was these have to be extracted, removed, and the implants had to be placed again, or there was too much of a compromise as far as the aesthetics of the implant prosthetics was concerned. We should be very, very careful about the implant placement also, not try to be over jealous about it, and then instead of putting 2, you put 3 implants and ruin the adjoining tooth, which might need to be treated by root canal or maybe try to extract it out. If you fail to plan, you are planning to fail. When we have a patient at our hand, there are certain criteria or should be followed up. The most important thing is you have a very nice, good diagnosis, clinical examination of the patient, the radiological examination of the patient. We can make the models out of it, and then you start proceeding ahead. When I go about, then I will talk to you about an anterior and a posterior way, maybe the simplest way what we used to do, and now what is the smart fusion technique which I am following. In the clinical examination, when you have, at the first hand, when you have a look at the patient, you just need to see the patient. You look into the thickness of the bone which is available. Sometimes it gives you a deceptive look. On the right side, you see a patient which has a very nice, good, thick ridge. But does this patient have the bone underneath to take an implant? There is a big question mark down there, because once you will have an X-ray, that's the time when you will be really able to make it out. How much is the thickness of the soft tissue available there? Even the one which is next to that also shows the same thing. Another picture. Here, there is a good amount of buccal resorption which has taken place. And ignoring that, two implants was placed, and then it was very difficult to restore this, and ultimately it resulted into a cantilever crown, which is a very dicey thing to provide because cantilevers are always bound to fail. When we have a look at the residual ridge, we try to look into the amount of thickness which is available. The minimum amount for the anterior is supposed to be about 3 point, depending upon the size of the implant, but we keep approximately 1 to 1.5 millimeter of bone adjoining to it. So supposing you're putting an implant of 3.5 millimeter diameter, we should have 1.5 or 1 millimeter of bone adjoining to it, so that the total becomes 5 or 6 approximately. In the posterior region, the minimum diameter of implant which we normally choose is about 4.3 or 4.5. So again, both sides, mesially and distally, you have to have an extra amount of space available for the implant, so that the total again becomes approximately 6.3 to 6.5, so that you can have a nice, good emergence profile. If you put in a very small implant in between, it will not be possible for you to provide the patient with a very good aesthetic by the end of the treatment. Moreover, when you are examining a patient, you must look for about any defect into the bone, maybe on the lingual side of the mandible, any concavity which is more prominent in the mandibular fossa region, or maybe in the anterior segment where you had a great bone loss. Examining the patient, you must have a look at the adjoining teeth. If the space loss is there, what is the condition of the bone, what is the condition of the soft tissue around it, and will it be possible for you to give a process in the type of cases which I have shown out here. If you provide a solution to the patient, they will never be happy and there will be constant food lodgement taking place. This was the clinical examination. The next step comes down is when you have a radiological. Radiologically, what we used to do, I personally find that IOPA X-ray or the CBCT are the only best solution. IOPA, if you cannot afford to get a CBCT done, whereas there is a magnification in IOPA and also CBCT. CBCT is not is 1:1 ratio thing. There is definitely some amount of magnification there depending upon the calibration of the machine, but they are supposed to be closest to 1:1 ratio. When we used to do in the initial phases and only a CBCT was not available, we used to get the template from the from the companies, and we used to use that for the using the magnification factor and take out the length of the implant which we wanted to put. But nowadays, CBCT is the X-ray of the choice for all the patients. We normally prefer to have a CBCT because CBCT always provides you a three-dimensional. If you have a comparison between an IOPA X-ray and a CBCT, you will always find that there is a difference in the view, because in IOPA X-ray, you have a look only from the one side, but when you have a CBCT and you cut a cross-sectional, there it gives you the defect there. Have a look here in the 2D and the 3D. If you have a look at a 2D, the IOPA X-ray, you will find that there is a good amount of volume of bone available. But if you have a look at the cross-section, you find the mandibular fossa there, which will not let you put an implant in the straight direction. So if you do it, there can be a big trouble. So it is better to evaluate on the CBCT, have a nice good look, and then proceed. CBCT will give you 3 dimensionals. So one is the bone length, height, and the width of it. After having a look at this, we have had a clinical examination of the patient. We have had the X-ray. Now, the third step is that you take an impression. Once you take an impression, you will be able to have an idea of exactly how much of the space exists between the 2 teeth. The 2 teeth means the mesiodistal, and then from there you can evaluate by the measurement that what size of an implant can come there. These are the different sizes of implants. You will add approximately 1.5 millimeter of bone, both mesially and distally, and club that together. And that is how we form that this much amount of space is available between the distal of one tooth and to the mesial of the other tooth. And so we can place an implant of that particular size. Another picture which again shows us that we have a size of an implant. We have approximately 1.5 millimeter or 1 millimeter of space adjoining to it. And that's how we get the idea about how much size of an implant we can place. Ridge mapping. You have a model in your hand. This is the oldest way of how we used to calculate the amount of bone available. What we used to do is we used to cut a section of the cast, and after that we used to measure the amount of soft tissue thickness which was available. With the amount of soft tissue thickness available, we used to calculate by reducing the size of the soft tissue how much of a bone is available, superimpose it, and then see that what size of an implant we can place. This was one part of it. The next step is you have a model, you have an upper and lower model. What you do is you do the setup. You have to put 2 teeth, 2 implant there. You do the setup, and using a BioStar machine, you create a template, a simple template. A template will be definitely a guiding force to you. It will tell it to you at least 2 things. What is going to be the point of insertion where you have to put an implant? And secondly, it will tell you also the distance between the 2 implants. So these are the only 2 factors which will be able to help with these templates which are there. But at least this will be some guiding force to you. No doubt it is not going to control either the depth of the implant nor the direction, but only the distance between the 2. This was all what we have been doing preliminary work for quite some time, and over the period of time you try to gain experience and then you move it. But in today's world, it is not the time of gaining an experience by experimenting onto the patient. So the things have evolved over a period of time slowly and slowly. And we will talk about exactly what the smart fusion technique is and how you can minimize your mistakes later on. Now I will talk to you about anterior replacement of an implant and the posterior. In an anterior segment, we have a case here. The tooth has been extracted and there is a labile deficiency of the bone. What we do is we just do a setup, put the tooth in the way, and make a template. We have a temporary prosthesis also ready. This template has been placed on the patient's mouth. Now you want to go ahead with the implant. If you remember, I had shown it to you. If you want to do a freehand surgery, you can do a freehand surgery, but what will happen? You will not be able to control the direction of the implant where you, but we want in an anterior area that there should be a very, very precise control, because little bit here and there, you will not be able to give a good aesthetics to the patient. So here is the patient's model. You have drawn the line at the incisal edges. Now, this is the axial direction. After having a look at the X-ray, you decide that this is the particular direction in which you want to put an implant. But remember, you draw a line. Here, the point to be emphasized is that you have to be on the palatal side of this line. You cannot cross that Lakshman Rekha. If you try to cross that Lakshman Rekha or the line, you will land yourself into the most difficult scenario where you will not be able to provide any good prosthesis to the patient. Now, this is the point where your point of insertion should be. If you move a little bit on the label side, your crown cannot be given and you will be quite far away from the label side. So this is the right particular point of entrance. And if you have a look at the tooth, this is the axial direction in which one should proceed. This patient's surgery was performed. It's a very old case. Ultimately, we did the grafting also in this case and provided the tooth to this patient. The next patient, so this is what exactly I was trying to emphasize, that we want to be absolutely straight and precise rather than to be more crooked and hitting onto the adjoining tooth. Now, similarly, we'll look into the posterior segment also. When you look at the posterior segment, this tooth was extracted, the bone healed. There was also a bony defect onto this, There was a bony defect on this side also, but we ignored it because we were getting quite a good thickness of bone there. We made the model, made the point of insert. First of all, the template was made. On the template, we used a drill and made a point of insertion just to make sure that where we are going. And then we replicated this into the patient's mouth. Implant was placed. This is the healing cap. And then ultimately, a crown was provided to the patient. Another patient, he had 3 missing teeth. Again, a template was made out here. I don't have the picture of the template in this case, but gave 3 implants and ultimately the prosthesis to this patient. That's how, if we proceed, we will be able to get at least the parallelism of the implants, and we'll have them placed at a proper distance also. So the ultimate prosthesis which will be given to the patient will be absolutely useful to. We do not want a situation to be like this. You can place the implant without any template also, but what if you have a situation like this where you're not in a position to provide any prosthesis? At this particular time, multiple unit abutments were not available, so we had to really give a compromised prosthesis to the patient. But nowadays, you have multi-unit abutment, you can change that. So we don't want implants like that. We want an implant that they can be put in the straight line. Traditionally, what we used to do is, when the templates were not being made, we just go and put the implants and then give the prosthesis to the patient. But now, things have changed. This implant dentistry is a restoratively driven. That means what I talked in the beginning, that your aim should be there. You should have an aim, and once you have an aim, once you have the end prosthesis or the final restoration in your mind, then only you will be able to proceed. So what we do now is we follow the virtual treatment planning workflow, which starts with the prosthetic need. Whatever we want to achieve, whatever we want to give to the patient has to be decided first. Then we use the CBCT, and using the CBCT, we use the implant at the later stage. In the virtual treatment planning, we use the CBCT, and we use the model, and you place an implant. After placing an implant, you also get an idea about what size of an abutment you will get, and then you can construct the tooth also on the top of it. So everything is pre-decided, and then you proceed ahead. In a guided implant placement, again, I'll say it's a restoratively driven surgery, which provides a solution where a doctor can place an implant virtually onto the software and accurately place them in the most safe and predictable. Because here you will have all the things in your mind or in your hand. You know the point of insertion, you know the depth, you know the width, and you know the direction. Everything is decided and predetermined. Once everything is known to you, you place the implant and then you enjoy yourself. Computer-guided implant placement has been divided into 2 parts. If you can afford the treatment, cost of the template, there you can get a fully fabricated template, or nowadays what we do is we get a template made which has only 1 point of insertion that again controls the point of insertion, 1 axis opening by which you know exactly where are you going, and you can control your direction to some extent, not much, but some extent. Here, there is a semi-guided surgery. Only point of insertion is under control. And in a fully guided surgery, you have a complete control because there is a sleeve, and those sleeves will direct you slowly, slowly to the final stage, and then you can place an implant in the final position. The indications are again the same, whether it's a partially edentulous, especially in the aesthetic zone. When you are dealing in the very delicate areas, it's always preferable that you must use a template to place your implant. And cost does matter, because if you get semi-guided, then the cost is much lesser as compared to the fully guided, because they have to incorporate the sleeve. The sleeve itself costs you about 6,000-7,000 rupees to fabricate it. This was a case where I did a semi-guided surgery. We had the CBCT done. Don't look into the pictures of the patient because the cleaning is not done properly, like we were talking about in the morning. Okay. This was the patient. We used the template. We did the planning first on the software, then placed the template in the patient's mouth and got the implant in position. In the virtual treatment planning, now what I'm going to talk to you about is the final step of it. We have done all single tooth, anterior, posterior, and the semi-guided surgery. Now I'll talk to you about a smart fusion technique. In the smart fusion technique, what we do is we take an impression of the patient's mouth. Then what we do is we scan the model, and we have a CBCT also. You try to superimpose the model onto the scan, and then in that scan, after you have fused the two data together, you have an exact position. You know how much is the thickness of soft tissue, you know the adjoining teeth, and you know the condition of the bone, even in the cross section also. With all that in mind and what all the data available to you, you place an implant in the software and then transfer the same thing into the patient's mouth and get exactly what you have planned in the software onto the patient's mouth. That's how you get an exact replica of this. And this is the benefit and the beauty of the virtual treatment planning is all about. In the virtual treatment planning, you make a traditional impression, pour a cast, scan the cast to record the patient's teeth in the edentulous area. Using the smart fusion technology, the data is combined with the data from the cone beam CBCT, and an image containing the details of all, the tooth form, the gingival form, the edentulous ridge, the cross-sectional, everything is there available with you. Implant position is also decided, angulation is decided, you get a template fabricated, and after placement of the implant, you can have a nice, good crown fabricated. I'll show you this case in the digital planning. This is a picture of the X-ray taken from the CBCT. Now is a impression, scanning of the model was done. The two data have been superimposed. You have the bone which is available to take the implant. You have the bone also there. You can very well evaluate how much is the soft tissue available, the adjoining teeth, and then the cast has been also scanned. The digital data from the cast was combined together, and now you have the tooth. The tooth which you are going to place into the patient's mouth, you can, from the software, you place the tooth there, you know the bone underneath it, and then on the top of this, you can put an implant. You have the final position of the implant also. On the left-hand side, you will see that this is a position and that the tooth which will come on the top of it. This gives you the diameter of the implant, the length of the implant which you can take it, and once you have placed it, the template is ready for you. On the lower side was the initial drill, and then is the final implant placement. Once this has been done, you close it, wait for 3 months' time, come back again, take an impression, send it to the lab, and get a crown fabricated. This is the digital planning and a guided surgery. Even in a single tooth or in the multiple teeth, since we are talking to you only for the beginners, it is better that you look at only at the single tooth. This was a patient of mine. I'm just trying to show this case because this was a very difficult one to handle out. She met with an accident and she lost 2 of her teeth on the upper left side. If you have a look, the socket was absolutely fresh. We did her scan. It was not possible because she had lost the tooth with the bone. And then we waited for about 3 months of time, let the soft tissue close, and let some bone form down there. And then using the smart fusion technique, we evaluated. Even when the planning was being done, we could see that the bone was quite deficient there. But had we opened up the entire tissue and tried to lift up the periosteum, it was not possible to give the patient the 2 implants, because then there would have been more of resorption which would have taken place. So we planned 2 implants and we did a flapless surgery out here using the template made for by the novel people, and then I gave her the 2 implants, and ultimately after 6 months. This patient, I have followed her up for last 20 years now. This is a 20-year-old case and still doing very well. That's how you learn and slowly mature yourself. Friends, experience comes from what we have done, and wisdom comes from what we have done badly. If experience enables you to recognize a mistake, then when you make it again. Now it's your turn, and thank you very much for your patient listening. Thank you.
I must compliment Dr. Sharat Kapoor for having given such a clear concept of how to place your first implant. Everybody thinks he's just going up the whole damn thing, putting it into the... But how well he spoke about it, how well he guided us. I think the young people sitting behind who've been busy gossiping among themselves should have learned something from you. The carry home message is implants are simple, but they need skill, not by talking behind the back. Thank you, Dr. Sharat Kapoor. It's been a very fine pleasure to hear you.
Thank you, sir.
Now I would like to request Chairperson to felicitate Dr. Sharat Kapoor, sir. Now, I would like to call upon our next speaker, Dr. Balaguhan, sir, for his lecture. And also request our chairperson to introduce Dr. Balaguhan, sir.
Dr. Balaji Gohan, a graduate of Sri Ramchandra University in 2007, probably needs no introduction here. Both of us know him so well. He's had an impressive career in the field of oral and maxillofacial surgery, spanning over 2 decades.
Okay, madam.
He has done his fellowship in craniofacial surgery and a fellowship of the Indian Board of Oral and Maxillofacial Surgery. He spent the early years of his year in cleft lip and cleft palate, having performed several surgeries in the entire spectrum of primary and secondary cleft deformities. His special areas of interest are minimal invasive craniofacial surgery, dental implants, temporomandibular joint disorders, primary and secondary craniofacial trauma, and orthodontic surgeries. That means he's left nothing for anybody else. He's too good in all of them. Please join me in welcoming Dr. Bala Gohan. But my request to all the audience sitting behind is to keep your movement as minimum as possible. Talk to your friends. I don't know. Women cannot stay without talking. But your distraction is far too much over here. The organizers can also keep this door closed so that the speaker does not get disturbed. Those who want to come in are welcome to come in, and those who are sitting here are welcome to go out now, not in between the session. Thank you very much.
Thank you. Thank you, sir. Thanks for your kind words. Coming to the topic, orthodontic surgery, it's more like aesthetic, but function is the main one, right? Coming to the common clinical dental practice, to diagnose a proper orthodontic surgery case, it's going to be very, very difficult. So many of the orthodontic surgery cases, it's either converted into a ortho cases or it's not converted into a aesthetically pleasing appearance. Coming to the diagnosis, where we stand for, first we have to check for whether it's a skeletal discrepancy or the dental discrepancy. If you're going to identify whether it's a dental or skeletal, then you'll come to know the diagnosis, right? Once you identified that is the skeletal discrepancy, it will go for either orthodontic along with orthodontic surgery. If it is going to be the dental, it's purely the orthodontic treatment management. If you diagnose it is a skeletal, then obviously the next step is whether first we have to do the surgery or first we have to start up with the orthodontic treatment. This is again the key area. You can get the help of orthodontist or a surgeon that they will decide upon this case is eligible for the primary orthodontic surgery or the primary orthodontic treatment. Here you can see the basic thing, the clinically, the dilemma, it's coming with the cephalometrics as well as the occlusion. That too, if it is the crowded or anterior open bite or the posterior open bite or cross bite, then our diagnostic dilemma is going to get delayed. So what we can do, how we can overcome it, because hardly 5 minutes or 10 minutes of time that we are going to take it in the diagnostic in our clinical setup. If this is going to be more, we can identify more problems, like we can identify each and every miniature things of this patient. So what we can do, we can take multiple photographs like this. The facial photographs, profile photographs, smile, all those photographs that is going to give you a key value for deciding the treatment plan. The usual ways, what we train for or what we plan for is go ahead with the frontal facial analysis, divided into 3, all those things, right? Is it going to be helpful in the new scenario? Do you think it's going to be helpful? The world is changing and AI is taking place. So what will be the choice? The choice for facial recognition softwares. What it will do, even if you want to buy a small spectacles, it will identify your face. According to your face, it's going to choose a spectacle and it's going to give. You can virtually, you can wear it and see if that is suitable for you or whether aesthetically pleasing to you or not. Then you can decide upon the purchasing of this spectacle. For one small specs itself, it's going to be this much of things. Think of facial surgery. Even these facial surgery softwares that can pick up very small movements of the face as well as the muscular attachment of the face, even that will give you a very good results. Coming to one step beyond, the simulation with the aging, that we can tell, right? The first series of pictures without any treatment, patient is the same, no orthodontic treatment, no orthodontic surgery treatment. So how she is going to look like? This is the series through the age. It's a stimulation. The second series, it's with the alignment of the teeth. This is going to be the futuristic age. So in AI, in facial recognition softwares, we can do very wonderful things, right? Coming to basics, we can't immediately adapt these kind of softwares into our clinical practice. So clinically, we have to set us 3-4 criteria. How we can diagnose early diagnosis a orthodontic surgery patient or its orthodontic patient. Coming to the facial analysis, you divide it into 5. Look out for asymmetry in each field. This is for vertical. Next one, you can go ahead with the horizontal, upper one third, middle one third, and lower one third, and you can divide in multiple one thirds in the middle as well as in the lower. So this will give you the very small picture. Then you have to come for a prominent of the face. The nasal bone, the zygomatic bone, the chin, all these portions are very, very prominent in the face. So you have to look out for these minute things. Coming to the asymmetry, the most of us will not be having a symmetrical face. If that is going to be asymmetrical, you have to check for the facial midline, whether it is going to coincide with the dental midline or not. And the chin point, whether it's going to coincide or not, that we have to check it for. Then you have to come to a conclusion whether the patient is having an asymmetry or not. That is for right and left. Coming to the facial angle, if you are going to drop a line from the nasion, that is going to be the straight one. If your upper lip and central incisor, it's going to be 1 or 2 millimeter just beyond the line, that is acceptable. 1 or 2 millimeter beyond, it's going for a retrographic. Coming to the nasolabial angle and the mentolabial angle, you can see and you can decide it off whether this patient is having a retruded chin or prognathic maxilla. These are all the clinical elements that we can immediately see and tell whether only the chin is retrographic or the maxilla is prognathic. Beyond that, you have to decide upon the teeth, how proclination the teeth is. This is to check up. This is the orthognathic surgery patient. Already it's finished for this patient for Lefort 1 as well as BSSO advancement and chin advancement for this patient. Coming to this patient, can you compare and see? Obviously, the lip incompetency is there. So obviously, the vertical maxillary is there. And if you're going to drop a line from the nasion to the perpendicular, the chin is way behind. And the chin throat angle is totally obtuse. There is no clear-cut line or the facial demarcations over there. So obviously, you can get it diagnosed. This case is for orthognathic surgery. Either prior to that, we have to start any orthodontic treatment, that we have to decide it on later. Coming to the dentition, if patient is having a cant like this, do you think orthodontically we can correct it off? No, the skeletal cant that cannot be corrected orthodontically. Only the dental cant that it can be corrected orthodontically. Coming to the anterior open bite, there are only two possibilities. Either we have to adjust the maxilla or mandible to get the open bite closed, or we have to extrude. Do you think 1 or 2 millimeter more than that we can extrude the teeth? That is also not possible. Coming to the maxillary incisor position, whether it's going to be coinciding the face or it's elaborately or protruding more than the face. With the rest and with the smile, hardly 1 millimeter of gum smile is aesthetically appealing. Beyond that, the gummy smile, it's going to give you a vertical maxillary excess. The same thing, bucket handle like the high mandibular plane angle. It looks like in the cephalogram, it's a high mandibular plane angle. It looks like a bucket. So obviously, you know that the mandible is way forward. We have to get it back. I mentioned you about, right? At the rest, if it is going to be more than 1 or 2 millimeter, then you have to check whether it's a soft tissue component is the short upper lip or it's the vertical component of the hard tissue. And beyond the smile, you'll come to know how much of the exposure that you can able to see. In this case, you can directly diagnose this is the case of orthognathic surgery with the vertical maxillary excess, and obviously the orthodontic treatment to align the teeth is going on. Coming to the dental, some of the patient will be getting a class 1 molar relationship. That's what all the orthodontists and we want, right? On these kind of patients, On these kind of patient, if you are going to go for a very smaller movements, we can utilize this class 1 molar relationship. If the arch shape is not good, then you have to expand the arch before going for orthognathic surgery. Coming to the upper lip to maxillary incisor relationship, the same thing, you can see the smile and the buccal corridor, then you decide it of whether there is a skeletal deficiency or not. In the first picture, you can see up to the first molar teeth. The second one, you can see only the buccal corridor, not the teeth, not the molars. Coming to the third picture, you can't even see the molars. This is the upper lip in relation to the maxillary central incisor. See, if one patient is coming with the reverse overjet, then we'll come to know obviously whether the maxilla is deficient or the mandible is prognatic. According to that, we have to correct along with the orthodontist. How to sequence this? So, first, you diagnose, you collect all the problems and put it into a list. Then, which and all is the patient concern that we have to get it corrected. Then, what and all your concern as a surgeon. Then, the next concern is by the orthodontist or by the dentist. All these problems that you have to put it into a same basket. From here, you have to get a treatment plan. You can see obviously the vertical maxillary excess for this patient. I'm putting 3-4 scenarios how to diagnose it. The lip seal is not at all there. And the vertical component, you can see the total incisor visibility. This is the post-operative picture. This is the surgically first approach. Only we can reposition the maxilla into a correct height. We'll be getting a good smile and good aesthetic. Coming to the anteroposterior excess, maxillary anteroposterior excess. If the teeth alone, it's forwardly placed, or whether it's the premaxilla and the teeth forwardly placed, that we have to diagnose. Then either you have to do a pure anterior maxillary osteotomy or two-piece osteotomy like a Lefort-1 osteotomy along with the anterior maxillary osteotomy. Coming to the maxillary anteroposterior deficiency, most of the cleft patients, they'll be having these kind of anteroposterior deficiency. If that is the concern, you'll be having the crossbite. Obviously, you have to expand the maxilla, you have to get forward the maxilla into proper position. Coming to the mandibular prognatism, obviously you'll be having a reverse overjet. You'll come to know the mandible will be already shown that picture. Mandible will be the high mandibular plane and the gonial angle it's going to be more obtuse. That is the mandibular anteroposterior excess. We have to get the mandible into a proper position. Coming to the mandibular deficiency, class 2 division A patients, most of the patients, they'll be having a class 2 division A patients, they'll be having the mandibular deficiency. These patients, the simple thing with the bilateral sagittal split osteotomy that we have to bring back the mandible into a proper position. Beyond that, if you need further advancement, you have to go ahead with the genioplasty. Coming to the chin deformities, most of the asymmetric cases along with the orthognathic surgeries that we can correct with the genioplasty. Almost 26 types of genioplasty types are there that we can choose which one to make it correct. Coming to the open bites. The open bite cases are a little bit challenging for the orthodontist as well as surgeon to get into a proper alignment of the skeleton as well as the teeth. The treatment option could be the Lefort-1 osteotomy or multiple 2-piece or 3-piece osteotomy to get the open bite closed. Coming for the planning, if you diagnose this patient is going to go for orthognathic surgery, priorly pre-surgical orthodontics they have to do. If the patient is ready for the surgery, then the concern is going to be whether it's a traditional way of planning or whether we have to go for a virtual surgical planning. The traditional as well as virtual, only the investigation criteria it's going to get changed. What traditionally we'll do, we'll take only the cephalometrics and beyond that we'll trace on the cephalometrics, we'll get a conclusion what the surgery is, proposed surgery is for, and we will be transferring all the data to the model surgery and we'll be getting like a orthognathic wafer or surgical wafer for the surgery. The same thing. Trace, transfer all the data to the orthognathic surgery for the articulator, get a splint done for orthognathic surgery. This is a case for traditional surgery. Coming to the virtual surgical planning, beyond the cephalometrics, you are advised to take a CBCT or CT scan. In this computer software, you change the maxillary position, mandibular position, or whatever way you can change and see the hard tissue position. You make a splint, and the last picture, nowadays we are not even making a splint, we are getting a 3D printed implant, the patient-specific implants for orthognathic surgery. You need not to take anything, the surgical wafer and all. You directly, virtually, you do the surgery in the computer and you get a proper position or the position whatever we want. Then you make a plates and screws that is 3D printed, you fix it off, the surgery is done. It's more simplified nowadays. This is another example case for 3D the virtual surgical planning. This is the post-operative. This decision making, it will make you a very better choice for orthognathic surgery. The advantages than the traditional planning, this virtual surgical planning, it's going to give you a very precise results. This surgical dilemma, how you are going to decide whether we have to do the surgery first or we have to do the orthodontic first. Coming to the surgery first orthodontic approach, the three things, the facial form, function, aesthetics, these three things it's going to play a very crucial role. If surgery first approach, very simple cases that we can do a surgery first approach without any the cross bite correction or open bite correction, all those things, we can do a surgery first approach. The orthodontic first approach, you align the teeth parallel to the bone, then you come for the orthognathic surgery, then you finish the case, you'll be getting a very good results. Coming to the decision making, these are the things that we have to summarize for initial patient evaluation, analyze for diagnostic records, multiple times you analyze the records, the diagnostic, and you make a problem list. The treatment objectives, what the plan for treatment along with the orthodontist as well as dentist. Then you virtually, you try in the computer, you see the result. If everything is good, then you go ahead with the surgery. Beyond that, the common dentist, they have to ensure the patient attenders, and you have to give all the consents for this orthognathic surgery because this is not the diseased one. We are doing it for function as well as aesthetics. So your thing, it's mainly important to convince and give hope for the patient. Thank you.
Thank you, Guhan sir, for giving us a nice overview of orthodontic surgery.
Thank you, sir.
And giving some pointers as to how the people have to plan the orthodontists and the oral surgeons together in collaboration, trying to create a nice facial, aesthetic, and functional appearance for the patient. Thank you so much, sir.
Thank you, sir. Thank you.
Thank you, sir. Now I would ask our chairperson to felicitate this speaker. Now, I would like to call upon Dr. Vidyashri Nandini ma'am to felicitate our chairperson. Thank you, sir. Now I would like to call upon our chairperson, Dr. Kavita ma'am and Dr. Vidyashri Nandini ma'am to chair the next guest lecture. Now I would like to call upon our new speaker, Dr. Rangarajan sir. He'll just join us in a couple of minutes. This is going to be the last lecture. After this lecture, you guys can proceed for lunch and come back by 3 o'clock for panel discussion.
So we have the PPT. நேரே போக வேண்டியது. ஓ.
Now I would request our chairperson to introduce our next speaker for the day.
A very good afternoon to one and all. I am honored to be introducing the next speaker, Dr. V. Rangarajan. Sir needs no introduction in the field of prosthodontics and all over India and internationally too. So I'll still give a short introduction here. Dr. V. Rangarajan, a graduate of Annamalai University in 1988. He earned a master's in prosthodontics from R. Ahmed Dental College, Kolkata, 1993. He's a renowned dentist, the first South Indian to receive Diplomate in Oral Implantology from International Congress of Oral Implantologists in 2003. He completed a fellowship in temporomandibular disorders, orofacial pain, and dental sleep medicine in 2018. He has delivered over 100 keynote lectures, workshops globally, and has appeared on several TV programs like Mangaya Choice to raise awareness about oral health. Sir, the podium is yours. We're all eager to listen to you.
Thank you. Thank you so much, Vidya and Madam. Thank you. Wonderful to be here. And today I'm going to talk about an often misunderstood topic, which is bruxism. We are going to go through some of the, what is the current detail as far as bruxism is concerned, and what really happens in bruxism, and how does it affect the restorations. This is what we are going to see as of today. And if you go through the history of bruxism, the first ever time was in 1907 when Mary Pigkewitz termed it as bruxomania or La bruxomania, and she was the first to describe this phenomenon itself. And in 1931, Frohman, he said he was the first person to use the word bruxism itself in 1931. GPT-9, I'm sure all of you have heard of GPT, that is the glossary of prosthodontic terms. GPT-9 describes bruxism as the parafunctional grinding of the tooth. This is the previous edition. We look at how the terminology has evolved over a period of time and what is the current status of bruxism and what GPT-10 gives us. Now, when we look at GPT-10, GPT-9 was a very simple definition. If you see the parafunctional grinding of teeth, that's all, nothing else. Whereas in GPT-10, which is the latest glossary of prosthodontic terms, you can find bruxism as characterized by repetitive jaw muscle activity, characterized by clenching or grinding of teeth. Not only clenching, the patient really does not need to clench or grind also. The patient can just, brace and thrust the mandible. There's no need to even for the teeth to meet. The mandible moving itself up and down is itself bruxism. And it has two circadian manifestations, as you all know, sleep bruxism and awake bruxism. So this is according to the glossary of prosthodontic terms. I'll be explaining this as I go on, with the lecture. So we have sleep bruxism and we have awake bruxism. Now, can you call sleep bruxism as nocturnal bruxism? Anybody in the audience? Can you call sleep bruxism as nocturnal bruxism? No, obviously, this is not something that happens during night. This happens when you sleep. So obviously, the word nocturnal bruxism is not supposed to be used at all. These were all old terminologies that were used. So do not use the term nocturnal bruxism. So either the patient is bruxing when he is asleep or he is bruxing when he is awake. So we will look at these two entities. And first and foremost, the more important entity is sleep bruxism. I'm going to talk about that now. So sleep bruxism, according to all these research, what is going on across the world, it is a repetitive jaw muscle activity characterized by clenching or grinding of the teeth. As I already told you all this. Now, two important things happen in sleep bruxism. One is called RMMA. What is RMMA? Rhythmic masticatory muscle activity. Your masticatory muscles are contracting. So that is very important. And the second terminology you should understand when it happens during sleep, and that is sleep arousal. We need to understand RMMA and we need to understand what is sleep arousal. So let me, go through these two things. What is RMMA? Now, RMMA is not something that is very specific only to bruxism, okay? This is a slow chewing-like movement, even in the absence of any tooth grinding. I already told you, you may not have any grinding of teeth. The jaw could just be moving. And this occurs normally in 60% of the people as a normal physiologic muscle activity. So RMMA is you and I also when we sleep, when we are not bruxers, RMMA happens in about 60% of the people, and the frequency with which it happens is about 1 Hertz. But what happens in bruxers? But 80% of Bruxers will have RMMA. The most important thing here is frequency is now 3 times higher. So frequency is 3 times higher and is also associated with tooth grinding about 40 to 50% of the time. So not always grinding of the teeth needs to be there. So this could be associated sometimes with tooth grinding. There are various types of RMMA. For example, you have tonic, where your, what should I say, this frequency, that when we check it, one EMG burst lasting greater than 2 seconds is called tonic, which is greater than 2 seconds is sustained. Phasic is less than 2 seconds, and you could have a combination of these two or a mix. So that is your types of RMMA. When we go into the etiology and pathophysiology of bruxism, how does it happen? What is the etiology behind this whole thing? So multifactorial, obviously the exact etiology is still not known. Even today, we don't know the exact etiology of sleep-related bruxism. A progressive shift definitely is happening from a peripheral view. For example, I don't know how many prosthodontists are here in this audience, but we had a classic article by Ramford in 1960. And he mentioned that, occlusion had everything to do with bruxism or sleep bruxism. Now we are moving away from all this occlusion, interferences and all that concept. We are moving on to a more central concept where the central nervous system has a much greater role to play in bruxism rather than all your occlusion and all these peripheral factors. So as I said, one of the earliest etiologies was occlusion. As I said, the occlusion concept was popularized by Ramford in 1961. But unfortunately, we now have enough data to tell you that occlusal interferences did not cause bruxism, and sleep bruxism activity was not reduced by occlusal therapy. We have enough proof of that or evidence of that. And there is similar prevalence of sleep bruxism in people with and without occlusal interferences. So whether you had occlusal interferences or not, you could still end up with sleep bruxism. So it did not confirm. Just wear alone does not confirm a diagnosis of bruxism. And tooth wear, as you know, need not be only bruxers will have tooth wear. There are so many other etiologic factors for tooth wear, like other sleep disorders, xerostomia, orofacial pain. So tooth wear could be produced by various other etiologic factors also. So as of today, definitely the one strongly held belief that occlusion had a role to play in bruxism is now totally out. We really do not even consider occlusion as causing or being any sort of etiologic factor in bruxism. as you are going to see later. So that also could be probably a reason for sleep. One of the etiologic, we are all looking at some of the etiologic factors. But another very important factor is your autonomic arousal response, meaning your autonomic nervous system has another important role to play. So I'm not going to go into great detail about all this. So it's accompanied, as you are going to see probably in the next few slides, sleep bruxism is always accompanied by increased sympathetic and brainstem activity. Almost every for 20-30 seconds, you'll be alternating. This is called as cyclic alternative pattern. And the active physiologic periods lasting about 3 to 15 seconds are called as arousals. These are the active periods. This is the time when, the person readjusts his body, changes posture, or when, somebody calls, listens. So that is your sleep arousal. Or if any harmful event is perceived, they become fully active. So this sleep arousal is happening at what is called as cyclic alternative patterns. Just imagine, this is the wheel of sleep bruxism. Understand that first, or at the, let's say, -4 minute. -4 means 4 minutes before the sleep bruxism actually commences, or the masticatory activity of the muscles commence. There is a rise in autonomic cardiac activity. Then there is a rise in brain activity. There is a rise in heart rate or tachycardia. There's a rise in suprahyoid muscle tone. And then respiration. Then finally comes to muscles. Then tooth grinding and swallowing. So imagine, so much of central factors have such a big role to play, and we keep thinking, occlusion has something to do, and we start grinding the occlusion and doing all sorts of things with the interferences. Sleep-related movement disorder. Now, bruxism was classified as a sleep-related movement disorder in 2014 by the ICSD. So that is another etiologic factors. Can you give me an example of a movement disorder? Any general movement disorder? So, haven't heard of any general movement disorder, all of you? Yes, Parkinson's. Parkinson's is a movement disorder. Now, this is a sleep-related. This is a disorder that actually happens when the person is sleeping. So, just imagine at what level we are, or the International Classification of Sleep Diseases has classified them. At the level of a movement disorder. And will it have any peripheral role to play? Absolutely nothing. This is another etiology that we are looking at, which people are, trying to do a lot of work on, but this could be another etiologic factor. Now, apart from all these factors which I told you, which could play a role in the etiology, we definitely have some exogenous factors. Like, for example, patients on medications or illicit drugs like substances like caffeine, alcohol, tobacco, SSRI, SNRI, these are all antidepressants, okay? SSRI, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors, Haldol, calcium channel blockers. So if the patient is on any of these medications or drugs, you could change the medication and you could see a reduction in the sleep bruxism levels. So there is some evidence that these exogenous factors have some role to play in, in sleep bruxism. I have done this for many of my patients with some effect. It will reduce the bruxing activity of the patient. Comorbidities, systemic, localized, and miscellaneous. All these, various, systemic diseases and factors also have a role to play. So you need to check it and you need to manage all these disorders so that bruxism can be reduced. So understand, it's just not something that is peripheral. And what is the current hypothesis? As of today, what do we view bruxism as? Is not a disorder by itself. It's not a disorder by itself. It could be a sign of a disorder. For example, a sign of Parkinsonism is a tremor. Is tremor a disorder itself? No, that's where we are coming to, okay? Bruxism could be a sign of a disorder. It could have different etiologies. It could just be harmless. Okay, absolutely no problem at all if that patient is bruxing. Nothing to worry. You don't need to worry about it unless there is some problem happening. It could be harmful, meaning patient could come to you with masticatory muscle pain, joint pain, tooth wear, prosthodontics, all the restorations wearing off, all those things can happen. But understand, all those are also multifactorial. We don't know if bruxism is really crossing. Most importantly, we now know that bruxism is protective. Did we even think before that bruxism was protective? No, we were only thinking it's all causing all the damages. So in two situations, one is, as I already told you, a patient with an obstructive sleep apnea bruxes so that there is increased patency, to increase the patency in the airway. So we don't want to stop them from bruxing. They want to increase the airway. Second is all these GERD patients, gastroesophageal reflux disease. Bruxism, actually, by bruxing, they generate a lot of saliva. So the acid that is coming to the mouth is now being neutralized by this saliva. So again, GERD patients will brux to reduce chemical wear. So two areas where bruxism is also protective. So it's just not to be seen as something harmful always. Bruxism could just be harmless. It could even be protective. So we need to take a call whether you want to, manage it or not, or when to manage it. So when we look at the incidence, there is some pretty high, data here, 10 to 30% in adults and 5 to 40% in children. And this may also be much higher because a lot of times these people are sleeping alone with no bed partner, especially the elderly, and they may not be aware. And also understand it keeps varying. For example, a person could be bruxing today, may not brux for some time, and again will start bruxing. So when you are probably taking the test, the person may not be bruxing at all. So it's very difficult to really point a finger and say, this is the exact incidence or prevalence of bruxism. And what are the clinical features? One of the classic clinical features, of course, masseter and temporalis, hypertrophy extraorally. Intraorally, you could have prominent linea alba and soft tissue trauma and all those things. And you could have wear of the enamel and dentine, restorative failures. All this could be classic clinical features of your bruxism. Now, how do you diagnose bruxism? Non-instrumental methods are self-reporting. Most of the times, actually, somebody comes and tells you, I am bruxing. Or his bed partner or her bed partner comes and say, I am bruxing. Self-reported through questionnaire or history. You look at the clinical features, linea alba, all those things I told you, and then you make a diagnosis. But the confirmation of the diagnosis of bruxism is only done with PSG, with audio-visual recordings. You need to put the patient or send them for a sleep study with audio-visual recording so that you will be able to see the, rhythmic masticatory muscle activity and then record and check it. So that is the confirmative diagnosis. Just by somebody coming and telling you I'm bruxing is not a confirmation of bruxism. Now, there is something called STAB for all those who are interested in furthering, the research on bruxism. This is a standardized tool for the assessment of bruxism. STAB is something to assess bruxism. How much of bruxism activity is in this patient? How much is there in that patient? So this is STAB. Axis A deals with the assessment, axis B with the etiology. Now, there's a lot of research going on. We still have not arrived at some kind of a definite assessment for bruxism. Research is still happening in this field. This is a good article for you to go through in 2020 by Manfredini, where there was an international consensus and they have started developing this tool or standardized tool for assessment of bruxism. How will you grade bruxism? possible, probable, definite. When is it possible? Some wear and tear, that is probable. But as I told you, definite. When do you say, okay, patient is definitely having bruxism? Only when you send the patient for a PSG with AV recordings. Only then you are going to have that kind of a diagnosis. So what are all the factors affecting sleep bruxism now? The intensity of bruxism. For example, every time the patient bruxes, an average bruxing event involves about 60% of the maximum clenching pressure. It's not more than the maximum clenching pressure, it's only 60%. And 66% of the events were greater than force of chewing only, and only 1% actually exceeded the maximum clench. And when we look at duration of bruxing event, surprisingly, they brux on an average only for 5 to 6 seconds per event. That's all. We keep thinking they, grind and brux for the entire night, but ranges from only 5 to 70 seconds. That's all is the amount of time that the patient actually bruxes. And is there any correlation between the position in which they are sleeping and bruxism? That is inconclusive as of today. Varied results with all the research. And patients generally do alter their sleeping positions. Bruxing patients alter their sleeping positions more than other. That's all we know. We don't know which position is better or which position is worse. Masticatory symptoms, because again, bruxism and pain is inconclusive. Why do I say that? Bruxism is like going to the gym and developing your muscles. So some patient has been bruxing for about 5 years, 6 years, 10 years. What do you expect? Do you expect any pain? You only expect hypertrophied masseter because he has nicely developed the masseter and the temporalis. You don't expect pain. So when a patient comes to you with pain, you really don't think or should not be thinking that this is actually bruxism causing it, because he is a person who's been doing this for many years. Why would this suddenly overnight cause pain? So there are various other things for orofacial pain, which we really need to go into this. The second very important thing is every time we see people brux, we tell them that their joint is going to go for a toss, or they are going to end up with temporomandibular disorders. Again, there is absolutely no evidence and no causal relationship has been established as of today that bruxism causes TMDs. Okay, period. It could be some kind of an initiating or perpetuating factor, but it is not a sole etiologic factor. And there is no evidence today that bruxism causes TMDs. As of today, that is the evidence that we have. Orofacial pain, this is a much larger, it's not temporomandibular joint. Yes, bruxism has a role to play in the general orofacial pain, which is more headache, neurovascular, neuropathic, all those kind of things. Bruxism and obstructive sleep apnea, as I've already told you before, have a lot of correlation. And be aware that the stabilization splints that we are giving to patients can aggravate OSA. How will it aggravate OSA? So does the stabilization splint that we give you increase the vertical dimension of the patient? I don't know how many of you have heard of a stabilization splint. A stabilization splint is a flat plane appliance, and when you give it to a patient, you will increase the vertical dimension. Now, when you increase the vertical dimension, what is happening to the condyle? Condyle is moving back. If a patient is going to have or suffer from OSA, you are going to worsen the OSA of the patient. So whenever you give a stabilization splint, you need to check whether the patient is already or test the patient for obstructive sleep apnea so that you are not worsening that condition. So I will come to it later. What will you do if patient has both OSA and bruxism? So we saw all these various factors, clinical features, etiology. Now, how do you manage bruxism? Behavioral strategies, some medications, And of course, we'll talk about occlusal appliances. All of you know, I told you already sleep-related movement disorders, so many things. So you need to get the patient to be on a good sleep hygiene, hypnotherapy, biofeedback, all these things are fine. And I told you all those exogenous things to be avoided. Smoking, alcohol, control the wake time, improve sleep habits. Mainly that is what we need to do, improve sleep habits. And of course, biofeedback and EMG may be less effective in sleep. In awake time, it's more effective because there will be some kind of a message sent to the patient that they are doing this, which is difficult to follow up in when they are sleeping. Medications, clonazepam, definitely 1 milligram, has demonstrated a 40% reduction in sleep bruxism. There is a lot of evidence for that. So you could start with about 0.5 milligram of clonazepam at night. And then I usually start even at 0.25 milligram. And then, if necessary, we can increase. And there are various other drugs also which could or have a role to play in reduction of sleep bruxism activity. So these are all the various other drugs which could be used. But all these are pretty, complicated, probably, drugs which you should prescribe only if you have some idea of their side effects. Now, coming to oral appliances, what are the kind of oral appliances that you give to the patient for a sleep bruxism? One is, of course, your soft splints and your hard acrylic splints. Soft is, of course, you can just, sometimes I think they give it over the counter also in many countries. You get a soft appliance, which is mold it, heat it, and fix it in the mouth. You can also make it custom made, like how we make a soft splint custom made, make an impression and do all that. So soft splints, this is what is a soft splint. The problem with the soft splint is they do not allow for any oral or occlusal prescription. You can't define the occlusion there. And they'll just chew off the splint also. They are less durable. You will start seeing holes in the soft splint soon. The patient is bruxing. And they are also sometimes, unfortunately, there is some evidence to see that they increase actually the masseter and temporalis activity. So they may not be reducing it. They may be increasing it and causing discomfort and pain in some patients. So soft splints may be okay for some time, but don't give it too much on a long-term basis because they are because of all these disadvantages that I have told you. Now, this is a good one. This is your stabilization, classic stabilization appliance or splint, which is basically a flat plane appliance where, there is even contact of all the anterior and posterior teeth. And this stays clean for a longer period. And you can get it to be adjusted to make sure that anterior and posterior teeth are contacting evenly. So that is the important thing. You could give the stabilization appliance either to fit the maxillary arch or to fit the mandibular arch. When will you give it for the maxillary? The maxillary arch is, of course, less retentive. You usually give it in a class 2 situation, and less cheek biting is also seen with maxillary arch appliances. Mandibular is more retentive, could give for class 3, but there is less retrusion of the condyle. So when will you give mandibular? When there's even, OSA, you could give mandibular because there is less retrusion of the condyle. All these partial coverage splints and all that have been tried, like your deprogramming devices and anterior repositioning, anterior deprogramming devices. But definitely I wouldn't use such kind of a thing because you will cause supraeruption and you're going to cause occlusal disturbances in future. So anterior and other splints must be used with caution as they may allow for unwanted tooth and condylar movements if worn continuously. Now, when will I give a repositioning appliance, moving the jaw forward or a mandibular advancement device? I will give it when the patient has a combination of bruxism and obstructive sleep apnea. So these are the kind of devices we give when the patient suffers from both OSA as well as with bruxism. You will give a mandibular advancement device. So these are some of the minor, negative outcomes of the oral appliances. And understand that the occlusal appliance is not doing anything. They are not treating, curing, or doing anything to bruxism. They are only protecting the dental surfaces from any wear and tear. That is all is their role. They have nothing to play with reduction in bruxism levels or in managing or curing bruxism. So be very clear about it. effect also seems very transitory, meaning, okay, patient could less bruxism after about few weeks, 3 months, a month or so, they may start to, brux again more. So just to protect the occlusal surface, that's all. We are not trying to really do anything else with these appliances. Now, on the restorations, really, does bruxism affect the restorations that we are, fabricating? That is an important thing, because we always keep talking of bruxers and, chipping off of porcelain, implant failure. Everything seems to be, all the blame seems to be on bruxing or bruxers. Now, looking at tooth-supported fixed partial dentures, okay, this is tooth-supported. What is the evidence out there that bruxing causes something? Yes, bruxing definitely causes technical failures like loss of retention, fracture of the material, and all this can happen. Biologic failures are also likely, like secondary caries and other things. So generally, metal restorations are where preferred. Today, we have monolithic zirconia, which is showing good results for bruxers because it doesn't have a ceramic layer. So monolithic zirconia is showing better tolerance. When we look at the ceramic materials itself, which material do you think causes a lot of harm to the opposing natural teeth? When we look at ceramics, have you all heard that ceramics can wear away the opposing natural teeth? So what type of ceramic wears away the opposing natural teeth more, and what type of ceramic wears away less? So does zirconia wear the opposing natural teeth more? What is in your opinion? Does zirconia wear it away more or less? Anybody? Make a guess. Nobody is going to penalize you. More. Okay. So zirconia. So what is the other ceramic that you have heard of apart from zirconia? Anybody has heard of any other ceramic? Have you heard of feldspathic porcelains? What is feldspathic porcelain? Where is it used? So feldspathic porcelains are the porcelains that are used on your metal ceramic restoration. All your porcelain fused to metal restorations are all covered with feldspathic porcelain. Previously, when we had layered zirconia, you will have a core of zirconia over which feldspathic porcelain would be added. Now, this is the biggest, causes the biggest wear. What causes the biggest wear? Feldspathic porcelain, especially non-glazed or non-polished feldspathic porcelain will cause more wear than your monolithic zirconia. In fact, monolithic zirconia causes the least wear among all the porcelain materials. So there is enough of evidence that monolithic zirconia is doing well, no biologic complications in a bruxer in about 2 years. And of course, this is a retrospective study. No significant differences in overall complications and survival rate with monolithic zirconia. And understand that when we look at occlusal splints and sleep bruxism, as of today, there's no control studies of the efficacy of such a protective device. Meaning we don't know whether it really protects or not. As of today, there is no study which says that, okay, using an occlusal device will protect your restorations. No study. This is for all you research guys out there to, start working on this. Occlusal splints and sleep bruxism systematic review. Again, insufficient evidence to recommend occlusal splint therapy. Okay, even if you find you're doing a full mouth rehabilitation and you think the patient is a bruxer, what do we normally do? We provide them with a occlusal splint. Now, there's no evidence that actually we're providing that you're doing any good to the restoration. Systematic review, another systematic review. So again, it underscores only one need, that we need to get more research work done in this field. We still don't know. Sleep bruxism and increased ceramic restoration failure did not favor any association between sleep bruxism and increased odds of failure of ceramic restoration. So we don't know. whether sleep bruxism is actually causing this failure, or your mismanagement in your occlusion that you did. You did not give whatever occlusion that was required for your restoration. So that could also be chipping your ceramic and various other things. So yes, laminate veneers, definitely there is some evidence that laminate veneers are affected by bruxism. There's no question about it. Most of the fractures and debonding occurrences were related to presence of bruxism. Now coming to implants. Does bruxism have any role to play in implant restorations? Yes, it is a risk factor associated with increased mechanical or technical complications like screw loosening or chipping of ceramic, but there is no impact on the implant survival. Doesn't mean that the implant will fail. You could have, screw loosening, you could have ceramics chipping off, but the restoration, the implant itself may not fail. So what do you do when you find that the patient is a bruxer? You may give additional implants to support your prosthesis. This is by Carl Misch, actually in 2002, okay? He advocated additional implants, increased diameter, eliminating cantilevers and night guards and all these things. Implants supported metal, ceramic, single crowns and fixed partial dentures were found to have a significantly higher risk of porcelain fracture in patients with bruxism habits when a protective appliance was not used and when restoration. So there is some evidence that in implants you're going to have this kind of a problem. Now let's look at those are all studies. Now this is a systematic review between implant restoration and sleep bruxism. A causal relationship between bruxism and implant failures has not been established. I told you there's no failure of the implant, but there could be some mechanical problems like fracture or chipping of restorations. All those kind of things can happen. Does bruxism has a role to play in complete dentures? What are all the textbooks on complete dentures giving, including mine? Bruxism is a frequent cause of complaint of soreness. Patients with bruxism keep complaining of soreness of your residual ridge. But again, that relationship has so far not been studied at all, or there is no evidence that actually it causes soreness. Same for removable partial dentures. We still don't have any systematically studied evidence on all these things. Finally, just a note, I talked to you all this while on sleep bruxism. Now, just to give you a few lines on awake bruxism, I told you it's totally different from sleep bruxism because this happens when the patient is awake. So this is viewed as a response to stress or anxiety and affect 20% of the population, more in females. Although it is a distinct entity, it appears to, there's people with awake bruxism could have sleep bruxism also. There seems to be some overlap, but the pathophysiology of awake bruxism may be more related to this central problem again. But this stress has a lot of role to play in awake bruxism. Of course, awake bruxism is more easy to manage because you can tell the patient, you are able to see that you're bruxing. So stop it, do something, all your cognitive behavioral therapy, all that will work with awake bruxism. So finally, in conclusion, the etiology of sleep bruxism, as I told you, is still under debate. There seems to be centrally